He hasn't replied yet, but I think we'll check.
All right, well, our best laid plans were that you would have a set of the slides that you could take notes on. Hopefully before we're done, you will walk with those. If nothing else, they will end up in the infamous Google Drive and perhaps some other format that, depending on age and technical capacity, you will be able to, take advantage of.
Or everyone, yeah. Also.
Yeah, you
I'm
can
on-
email it to everybody right now for anybody who's so do I put this from the beginning? Yeah, so. And I would say out loud to the people on the online, if you can't see anything or hear anything, please, put it in the chat and Arturo is monitoring the chat. We will try and fix it on our end. Okay.
You can see it.
Okay. All right. Today, we have a pretty steep agenda. This is a complicated topic that, I'm going to give you a high level overview of and sort of discuss a pathway or roadmap for y'all to consider, whether it's within your own organization. Some of it may be with RAzCHOW, however you want to think about it. We'll have a conversation at the end of it, but I want to just give you some context around what's happening with Medicare and community health worker reimbursement. Yes, ma'am.
What we can see on the video, it's not the same slide. It's still showing the intro slide.
Yeah, see, I don't know why it's doing that. He said it's screen two, yeah.
Oh, now it's good.
Thanks for noticing. Now it's good.
Yes, now it's good.
Just do it this way, the old fashioned one. All right, we can do that. All right.
I can fix it.
We want to, so like, I mean, there's some detail there. Wave your magic wand to keep it.
The more fancy technology, the more.
No, I just.
Yeah.
I'm waiting. Okay, so, today I'm gonna give you a brief
And
orientation.
that's what we did, Richard, right now. That's how I had it, but that they can't, they weren't able to see.
It should be the same now. The doc is.
We won't know till you change slides.
All right, well, let's change the slide just to change provocative.
Yep, we're good.
Okay. Yep, that would work. So, all right, so we're gonna do the first portion of the presentation is gonna be just giving you some context around what's happening. One thing about being a good network and being together is that you keep your eye on the horizon. You're constantly scanning the environment to see what's going on, what's gonna move your cheese and be ahead of it, as opposed to always being reactive to it. And that's kind of a theme that's gonna run through today. Being proactive about lots of things, including the care that we're delivering to people. And so, I want to give you, for some of you, it will be old news. For some of you, it may be new news, but just get us all on the same page about what's happening with it. And today, I'm talking about Medicare. I am not talking about Medicaid. And I know many of you live in the world of Medicaid, but there are opportunities for you potentially in the land of Medicare. A lot of opportunity that's coming, and that's what we're going to talk about today. So the way that Medicaid operates in this CHW space and in this billing space at the moment is different. And so there is a path that y'all are on with Medicaid in Arizona for CHW billing. It is great, it is fine, it is wonderful. But there are parallel systems at the moment, or I wouldn't even call them parallel, but they are running on different tracks that eventually will align sometime, probably starting in 26 or 27. It's not, it is imminent, but the pace at which we do it is to be determined all by CMS. So we're going to talk about generally is the context and where these, what they're called now, health-related social care need codes. They're health equity codes. So they're right in the wheelhouse of all the work that you're doing. It's exactly what you're looking for. And then we're going to get into some more detail around operational considerations. So I've got some, you've got your handouts that will be giving out some of the workflows, just schematics of this is how it could work in each of the billing codes and how they could work. We're going to talk a little bit about what the service fees are themselves, some financial modeling around that, contracting considerations, because this is going to look a bit different potentially than what you're doing with Medicaid. Talk about a sample clinic workflow. I have set this up mostly in the context of FQHCs and rural health. But there is a world of opportunity for you out there working with private physicians, hospitals, specialists who deliver service potentially.
And behavioral health providers.
Yes, yes. Yeah, yeah. That's not the driver. There's a whole lot of other clinical integration codes related to behavioral health integration, but absolutely somebody who's mentally ill, depressed, as a condition can absolutely be eligible, particularly for patient wellness navigation. We're gonna talk about a brief little idea around a case study to reflect what we've been talking about all morning, to just sort of apply those principles. And then tee up for you the idea behind a draft pilot that you could do within your own organization, or finding a partner in the community, a CBO partners, and introduce you to a capacity survey tool for your own organization, sort of say things like, you know, we thought about that, or we haven't thought about that at all, or but starting to look at what that continuum is of development for you and a partner to work together to do this work. It'll make sense. I'm done. Then we'll do some Q&A, and I want to say right now, stop me at any point and ask me, and folks in the back, if I'm talking too fast or you need me to stop and explain it. And then we're gonna spend the last portion of the morning before lunch talking about what, after all that you hear this morning, what do you think the role for RAzCHOW in all of this supporting you and your organizations, or you as a collective, could be doing together to help move the ball down the field for this? Okay, make sense? All right, so this is it. New health equity service code, health related social needs. And like I said, we will get you those slides. All right, so for some context. Many of you who have worked in and around healthcare for a number of years, you hear about value-based contracting, you've heard about clinical integration. So that's hospitals, skilled nursing, physicians, specialists, all working together, being able to share information in ways that they haven't been before. Has anybody ever heard of an accountable care organization? Okay, so that is, if you have any of those in your neighborhood operating, they're a great place to start as a clinical partner to pilot this work with them. But they're all used to sharing information. They've gone through all the legalese to negotiate, sharing data, protected health information. They're sharing resources and money to try and deliver better care, meet better performance measures, and save money to the system. So we've been doing that since the Affordable Care Act. It's probably 10, 12 years old now. We certainly don't have that all perfected yet by any stretch of the imagination, but that train has left the station. Hospitals, clinics, skilled nursing, they all know this is the path they are on, and there's no getting off of it. CMS is not letting them off, so they're full steam ahead to total cost of care type of finance models. Now, and I'll get into a little bit in the next couple of slides, but they're very interested, and y'all know this from the work that you've been doing for 100 years, is there is a appetite and an interest to integrate social care needs and wrap that around the clinical needs. And the people that pay the bills, CMS, finally have gotten that, and they've listened enough from the field for the last 20 years, and they finally are giving us something to work with. And that's what we're going to be talking about today. CMS came out recently with these 5 strategic pillars that are new for them. And so in the spirit of environmental scanning, knowing what's coming, CMS is the biggest insurance plan in the world. We pay CMS between Medicare and Medicaid is the biggest insurance company in the country. Okay? They don't like to be called that. Nobody likes to think about it, but they pay the bills. And so when you're the big boy on the block, you have and control of all the policy, you dictate sort of where things are gonna go. And so they've had this pivot, which is a great thing, to wanting to advance equity, really truly in a meaningful way, improve access to care, work in a meaningful way with partners. For those of you who've been in the business for a very long time, CMS was always viewed as punitive. They were an enforcement organization. They would come in, they would make you pay penalties. They were the big bad police of healthcare. And they don't want that reputation anymore. So they're trying to retrofit themselves. And they truly have been great partners in listening. So, you know, one of the things we're going to talk about later on with RAzCHOW proper is at some point during the next few years with this network development grant, it may be very appropriate with the feedback that comes from you for them to take a visit to Rockville and go and visit CMS and tell them about what the experience is and how this whole system is working or not working for y'all. And they really truly are interested at the Innovation Center to hear that. They're looking to drive innovation. Innovation comes out of need and necessity. And if there's ever a group that knows about need and necessity and being creative, it's you people out in the field on the front line, trying to figure out how can we get this thing to work, whatever. We've been given this sow's ear, and y'all always manage to make a silk purse out of it, okay? So they're really interested in what are the solutions that you're coming up with. So trying to keep track of some of all of that so that you can tell a coherent story. You know, we talked about the data and the evaluation, all of those questions yesterday. Be thinking about the information that you're collecting. And so how that can then help inform this process. They want to protect programs. So with the eye to sustainability, which is all the work that we're doing with you, CMS too wants to, you know, what's the good stuff that we have and how do we grow that and bring it to scale and make it sustainable? And then obviously fostering excellence. You know, there's no room anymore for poor, shabby care. They're really looking at how do we make these meaningful and right and producing good outcomes. And just the value-based care piece of this, if anybody cares, there's some bullets there about the direction that they're heading with rural providers. So you're all doing work in a rural space. Just knowing that these things are coming, they are pushing for all providers. Their goal at CMS is that 98% or something in the next by 2030 of all Medicare payers and all Medicare beneficiaries will be covered by some kind of a value-based payment arrangement. So people are going to have performance measures. They're going to have to start collecting their own clinical data. They're going to have to start improving what the outcomes for that diabetic, that heart patient, hypertense, depressed. They're looking for results to come from that, and you're going to get paid on it. And at some point, just like they do with an accountable care organization, I used to run one. If you're a failing provider, it is your obligation to cut them off. You should not have them in your network if they can't do quality work. So CMS, I think, at the end of the day, will sort of say, you can't be a payer anymore. I mean, we're not going to be a player. You cannot, we will not accept you and pay for Medicare services for you.
What was the percent of Medicare covered individuals that CMS wants to have under a value?
It's high. It's, they know it can't be 100%,
Okay.
but it's somewhere in the high 90s.
Okay.
I would say 98. If you go to their report, you can get the statement. And that is a very fast track, right? This is 24, we're halfway through the year, and they want to be there by 30. I'd say it's an aspirational goal, but they are full steam ahead in pushing all of this. And for those people who work in healthcare plans, they're getting pushed on heavily by CMS to move in that direction. They're also interested in expanding the number of Medicare Advantage plans and exchange plan offerings that are available in rural areas. I think Arizona, you have a pretty low penetration of Medicare Advantage. There's not a great penetration of it. So that's the managed care program for Medicare. Like, you're probably more familiar with Medicaid managed care in Arizona. Out in the rest of the world, you know, like where I come from in New York, we have close to 60% of our Medicare population is in an Advantage plan, which means it's managed by a commercial plan. So it's like a United and Aetna. We have a lot of regional plans that cover what we do. And so there's going to be a big push to try to move a lot of your fee-for-service Medicare, traditional Medicare members into plans, and they're going to be banging on the plans to sign up physicians and clinics to get them to participate in all of this. Like it or not, that's the path we're on. Increasing the quality of rural healthcare by focusing on reducing readmissions, reducing hospital-acquired conditions, and improving maternal health care. Okay, those are their big pillars that they're focusing on for rural. We are infamous across the country for bad use of emergency departments because that's become our primary care, right? We go there when the foot's gonna finally fall off. You try and muscle through for 6 months and you can't do it anymore. It becomes so acute, you end up. So, that costs a lot of money to the system. And it's not good for the person, right? I mean, if you've got a splinter in your foot, why does it need to become septic 6 months later? I mean, there was no excuse for that. So that's where they're heading, getting further ahead of disease management. Promoting and encouraging the adoption of telehealth. So I cannot stress to you enough how much the rest of the world thinks that telehealth is the solution for rural, is the solution for rural. We know that is not the case. We know that we can't even get telehealth into a lot of places still. They're working feverishly to try and resolve the bandwidth issues and the cellular issues and all this. But just beware that access equals telehealth from a health policy perspective around the world, because it's the easy button, seemingly. And we all know there's a lot to that. But you are a very rural state with very remote distal points and challenges with mountains all over the place to get reception. So just keep an eye on that. Again, scanning the horizon, knowing what's coming. They're moving us to telehealth and rural. And there's a lot of great stuff that will come from it. But be in control of your own destiny. Don't be caught with your head in the ground thinking this isn't going to happen. Really be thinking about it. Where are the opportunities? There's a whole, a whole book of grants through the Federal Office of Rural Health Policy that deals with telehealth implementation, trying to figure out remote patient monitoring, all of different kinds of applications. So be thinking about that as a group, as to what you might want to do. And then reducing the administrative burden of the impact of all of this policy. So they realize that all of you sitting around this table, I know I've done it myself, you have 3 jobs. You don't just have one job. There's the quality improvement division in Phoenix at some health center, and there's 6 people on that quality team. While you're doing that along with contract negotiations with insurers and also working on the floor, have a full-time equivalent each week. So they realize that the documentation and all of the things that come along with this can be a challenge. So they are working to try and figure out how do we create those efficiencies so that reporting burdens don't bring you down. We need that rural data. We need that performance improvement. We need to be able to collect it. But how do we make that easier on you? Because we don't have a team of 6 to go around and do chart audits all day. All right. So everybody's heard the whole terminology. We're moving upstream, right? Social determinants of health are there's a lot of talk out there, and I want to say we use the term social determinants of health in this universe very inclusively and loosely, and it's one of those things kind of like care coordination. It's got 94 different moving parts to it. It's like being a community health worker, right? Are you a patient educator? Are you a navigator? Are you a community health worker? So social determinants of health has become one of those loaded statements. And for the purposes of, again, getting in CMS's head and the CDC, the social determinants of health are really high-level policy, hairy problems that need to be dealt with way above our pay grades and our community influence levels. So those are the things, the community impact, those tactics and strategies, that's where social determinants of health belong. But what they realized, finally, they had their moment of clarity, that for years and years, clinical care has been operating in this downstream environment, passively receiving whatever walks in the door. And now we're asking in a value-based world that you do a better job of managing that diabetic patient, which means you got to move ahead of it. So population health management, I heard somebody talking about it yesterday. There's public health population health management, which is that, whole county, whole region, big numbers, big ends. In this case, with clinical care, population health management is knowing what's happening within your patient population. So I'm Mariposa Clinic, and I have 544 diabetics, and I know who my diabetics are. And now I can drill in and know what I'm doing with the care for each one of those diabetics. And I know whose A1Cs are out of control or who hasn't been to the clinic for a blood test in the last 18 months. Are they even still my patient? Whatever. So proactively going out and trying to bring in those people to manage their care. So that's what they mean by population health management. And clinics, for those of you who are in that environment, you know that you get paid based on, or starting to get paid based on how you're performing on the number of patients that you identify as diabetic and how many of them had their A1C in control. All right. Now, we have had the moment of clarity that we can't just give them metformin, we can't just give them insulin, we can't just hand them a note that says, here's a diet that you can eat. It doesn't work that way. So they are now moving into this midstream space with what we're talking about today, which is individual impact, and it's more precision medicine, if you will. If you think, do we know anybody who's been in cancer treatment of late? And remember, it used to be like, we just bomb you with chemotherapy. You have cancer, you have cancer, you have cancer, we're just gonna bomb you with chemotherapy. That was like, the nuclear option. Now we've gotten into something called precision medicine. People are starting to DNA type the cell, or whatever, be very careful and precise about how we're delivering the treatment. That is where, and at the very beginning parts of trying to deal with on the front end of patient care. Instead, eventually we're gonna get to where we're trying to head off people with a high glycemic index, who really are hypertense or obese, and trying to get them under control before these other disease states ever develop. But the idea is that you use the social determinant of health screening tools, and you get people wrapping their arms around people to get them what they need in order to manage their care. That makes sense. I think it's a pretty daggone good idea, and I wish this had happened 30 years ago when I was doing this work. So then, you saw this groovy little thing. Everybody's probably familiar with this guy. Okay, that's the traditional look of what we mean when we talk about clinical care is only 20% of a person's health. All these other factors, socioeconomic, your physical environment, your health behaviors, all of those other things have a much bigger impact on what happens to our individual health. And some of you may recall this structure is from the county health rankings, if any of you work in that space. So what I want to pull your attention to for the rest of today is the social needs. The social health care needs are the green circle with all of the things like housing, utilities, childcare. You will see it does not include employment, education. We are not trying to boil the ocean with these clinics, with these codes. We're trying to just help somebody manage their disease by helping them get extra services and extra help, education and support to manage their disease, okay? Baby step. Yes, ma'am.
Can this operating from New York State, what does not trying to boil the ocean?
Oh, it's like solve all the problems, in the world, like do it all at once. You've never heard that term?
I never have, I don't know if anybody else can. I was kind of guessing, but I'm thinking, is that like a climate change thing?
It's an East Coast term.
It's an East Coast.
Yeah, because I've used that and people here have looked at me like I'm from the second head.
Thank you.
Well, good question, thank you. So then health equity services, I don't have to tell you all this, it's just, we're moving upstream by adding these codes in. The belief is that by doing this work, we're gonna create better access for people, which remember, it's one of the pillars for CMS. Because you're gonna be handling these people, you're gonna be getting them, navigating them to, services that they need. And enable the building of clinically integrated partnerships between medical and social care providers. So at the end of the day, you know, I mentioned earlier the clinical integration systems. We're now on the verge of trying to build clinically and socially integrated care systems. And this is the baby stuff. All right, so enough of that. If you have any questions about what that stuff already we talked about? No? Okay, good. All right, so now we're getting into the meat of the Medicare piece of all of this. So in 2024, there's this thing called the physician fee schedule that gets issued every year, and all payers look at it, get it. This is what you can go off of for your services that you deliver. And so in 2024, so late 2023, because they issue these things like in the fall. Like right now, we're in public comment period for what's gonna happen in 2025. 24 came out and included these new codes. Because they weren't released in time for insurance plans to file their plans for 24. They have only made this available in 2024 to Medicare fee for service patients, okay, traditional Medicare. So right now today, as you have your thinking cap on, the only beneficiary pool that has launched in the country are Medicare fee for service beneficiaries. So that means people who are traditional Medicare, dual eligible, SSI, and end-stage renal disease. You probably don't much with this, folks. Medicare Advantage and Medicare Advantage and special needs plans have a statutory requirement to cover all Part B benefits, but they didn't have time. They have every year, they have to go to CMS like around July-ish and submit their plan for the upcoming year for how they're gonna, what they're gonna do. They submit it to the state and they didn't have time to do that. So I just have talked to some people working in plans in other states, and CMS was not very directive for what's happening in 25. So I think this is gonna be on a slower launch maybe than we even thought. But eventually you can be sure that Medicare Advantage and commercial, even the people, you know, whoever we're insured by our own payers, for our regular commercial adult health plans will be obligated to offer these services to someone. The new services that we're going to be talking about today, I'm going to stress again and again, which is a little bit different maybe than what happens with Medicaid in different states. But this is for navigation and education services only, right? So you cannot cover the intervention. So a lot of times in Medicaid, people will allow, you've identified somebody with housing instability and you're allowed to help underwrite like their damage deposit or their first month's rent. Or you can purchase medically tailored meals for somebody that needs them, like 2 or 3 months ago. This will not cover that, okay? It's the time spent educating and navigating the patient, right? And these are the 3 buckets of opportunity for reimbursement. So there's this community health integration, which is the main one I want to talk about today, because that involves relationships and CBOs, community-based organizations. I'm sorry, I'm really go right here. There's principal illness navigation, which are people who are diagnosed with that, and the rules around it are slightly different. And then there's patient illness navigation peer support for seriously mentally ill and others. But those are the 3 buckets they fall into, and it's really just 2. It's community health integration and patient illness navigation. Okay, and from now on, I'm sure I'm gonna lapse into it, I'm gonna call it CHI. So community health integration is that first code. You'll see it abbreviated a lot. All right. So the services encompass a person-centered assessment. We're gonna do some work on that. That's the SDoH screening that has to be done. And what they're looking for is to better understand a person's life history, the context in which they live. So you can be able, all of you as a team, clinical, community-based, do a better job of helping to support the person. It's an expansion of existing care coordination and case management services that clinical providers are pretty used to providing. So it's just another set of codes and a deeper, richer service that's going to be available. Like I said, contextualized health education, as you do those assessments and you start to uncover some things and you're having an interview with somebody, you start to learn about it. It helps you tailor the education and the recommendations, right? You already know this. Help them build self-advocacy skills. A lot of people are caught in that, woe is me, I'm a victim of circumstance, life has been so rough on me, I can't do a doggone thing. This is an opportunity for community health workers and others to work to try to build up a person's understanding, help them learn to be a better advocate, grow their personal empowerment for managing their own care, because you cannot do it for them. All you can do is lead them to it. Health system navigation, we've got a fragmented, hot mess of the system, if you want to call it that in some places. So helping to get people where they need, particularly the patient illness component and all of that. Facilitating behavioral change, right? That falls, that is encompassed under there. Providing social and emotional support. Have developed a relationship. That is A-okay. You become their go-to person in the health system. Help me with this. And then you hopefully have a team of people that you can lean into to help you. And then facilitating access to community-based and social services that help address unmet social needs that they have. So that's kind of the vision, and that's all of what aspirationally comes under the hood of that. So the key concepts for the community health integration, okay, that's that first one. It is the first Medicare benefit that provides a direct pathway for community health workers to be reimbursed for providing service. This is huge. Heard it here first or not, but this is big news. This really recognizes the value and the importance that many of you have been working in the field for 20, 30, 40 years, trying to advocate for. And the time has come. And so one of the reasons I want to talk to you about this today is to see how we can start to push some claims into the system to help test it so that it can be reshaped and refined to work better. But right now, see, it's so new. CMS is kind of sitting there going, how's it go? Nobody's had a chance yet to figure out how to submit a claim. And it's going to be massive. We can talk about that. No question about it. That's why we want you to start small. But it's a real opportunity, and you can have people to come to Eligible Medicare providers can allow auxiliary personnel to provide the services. So what that means is it doesn't have to be a clinician who does this. It can be someone operating under the auspices, under the direction of a clinician. Whoever's doing the billing, so it's the doctor, the nurse practitioner, the physician assistant, anoints the team to be able to do this work. You're doing an incident to, for those of you who work in the billing world. Medicare providers can contract with community-based organizations to provide these education services. That is exactly what CMS had in mind with this particular code. They know that clinicians generally do a pretty rotten job. Hospitals do a pretty rotten job. Apologies if there's a hospital sitting in this room at delivering these types of services. And that there are many community-based organizations, like many of you out there providing your service, that know full well how to do this. You know the neighborhood, you know the people to talk to, you know the language, you already have the trust of people in the community. So you are, for lack of a better term, I like to refer to you as an IST. You are a specialist. You're a community outreach specialist. You are as special as a radiologist, a cardiologist, or an orthopedist. You are an IST. And so they are able to refer out to you for your special skill set and training to be able to provide these services. How does it feel to be an IST? I have a lot of physicians, pediatricians who don't get paid very much in the system. I always want to be an IST. I keep thinking I should go get a specialty and become an IST. And here you are. Sorry. It requires a social determinant of health success. And the language of assessment and screening have great meaning. I'll talk a little bit more about that. And they have to be documented in the health record. For those of you who work in a clinical environment, there's something called HCC coding, hierarchical information code. And it's used to determine what each one of us is worth dollar-wise in a year of cost in the plan, in the whoever year is paying for your health insurance. So it's really important. Every year, the doctors for years have been beat on. If you want to get the right value for your patient, you want to save money, it's important that you code the person the right way. So every year, at the beginning of the year, physicians have to go in and paint a new clinical profile of each of us into the system. That's why the annual wellness visit or general wellness visit that you have with your doctor becomes important. With older folks in the Medicare system, they tend to be older, sicker, of higher need and higher cost. That's why we're focusing on this. You want to make sure that you know that they are diabetic, they are hypertense, they are an amputee, they are any number of things. So when they've been doing this hierarchical condition code profile, it says that you're worth $5,000 into the system every year. We think that's what you're going to cost, and you're going to cost $7. You're a hot mess with what we know about it. You're going to be 17, and you're a frequent flyer at the ED, and man alive, you're going to be worth 22, and whatever. But that's based on what they know. What this work, what these SDoH screenings is going to do is try and help enrich and fill out the flesh a little bit more around what's happening with each of you. So all of a sudden, if I know that you're diabetic, amputee, hypertense, using the ED a lot, and now I know that you're unstable housing, you don't have a clue about how to prepare your food, and your refrigerator's not working, so you can't keep your insulin cold. I mean, that all starts to create a richer picture, and all of a sudden we'll add more value, if you will, to the price point. So all of a sudden, my hot mess here with Chad, he's gonna now be worth maybe 20. And I forget your name.
Camilla.
She was our all-star. She's on the flag list, she's on the hot spot list. And she's now maybe gonna be worth in the next year $25,000 to the system. But they want to get right what they need to expect to spend on people. And once we know what we got, then we can start to figure out systematically, how do we manage it better? Make sense to you? So these codes in this profile makes a lot of, it's very important. Yes, ma'am, I see the hand going up.
I'm still formulating my question.
Okay,
I'll ask it.
you chime in when you're ready.
Yeah, I'm just
Yes,
thinking.
ma'am.
I think I might have experienced some of this. I might be the only person that isn't on Medicare. I think. But, when you're on Medicare, you have to have a physical every year with your provider, which is great. And it usually comes up in October. I went for my physical. I was in my car. I was actually starting to back out of the parking lot. This is a provider I've gone to for like 20 years. And the nurse, his assistant came running out and said, Susan, can you come back in? I said, she goes, I don't think you noted some stuff, right? She goes, are you diabetic? And I said, no. And she goes, come back in. And so it was like, I don't know if he went really fast or what, but there was stuff checked that it was not me.
Yeah,
And she also said that I would have probably gotten charged for some of the labs because they weren't done right for a physical, which is all three. And anyway, so.
yeah, yeah, but you're right. So, and I love the fact that she raised after you, because that means ding, 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 we're starting to pay attention,
Yeah,
and we want to get it right.
Yeah.
All right. Now, next big point, again, stick with my new phraseology, that y'all were not familiar with, boiling the ocean. So we're not dealing with, whether they can read or not, whether they have a job. We're focused on what may be getting in the way of the individual's ability to manage their own care for whatever this disease state may be, right? So we're not gonna, if they get a lot of triggers on the SDoH form, I shouldn't say that's fine and wonderful, but the things that have to be captured and that are eligible for the billing have to be directly tied to the fact that they're diabetic and they're not able to manage because of housing instability, transportation, medication hindrance, those sorts of things need to be present. So again, very focused on the disease. Think about that midstream, we're trying to help people manage the disease. Different.
Okay, so for this, something like, would a language barrier then count or would it not count?
That in and of itself has not been identified as a determinant of health.
So my question is, why? Because
I
like
know,
our,
don't ask me. I'm just
Okay.
way above my pay grade.
okay, yeah, I was just curious, because like, we work with indigenous populations, for example, our organization, and there are a lot of very rare languages that if someone doesn't have a family member who can do that translation for them, you can't just call a translation number and get it to translate. We've even tested this. I must have called, I think it was like 12 different translation companies just out of morbid curiosity to see who could do translation in indigenous tongues just in Arizona. I found two that could only do a handful of languages. So it's, that would be a challenge then.
Another thing that they're required to do, the plans are, the clinicians are the race, ethnicity, and language assessment. That's all part of the intake. That is not part of the social determinant of health piece of this.
So that responsibility then falls on the provider then, even if there's not availability for the
Correct.
languages.
They are mandated to be able to communicate. And they do the best they can, I mean, right?
Yeah, I'm just trying to think through in my head the barriers for it, because like when we worked at the hospital, when I worked at the hospital, we had numbers we could call, we would have translators come, we literally had a list of staff who could do translation services, competently versus on the fly until the translator could get there. So we had like this whole hierarchy of individuals, like, okay, the translator is gonna take them 20 minutes to get here in person, but these individuals can do like baby translation, just to let them know to kind of wait, get them water, get them whatever it is they need, help them to start the paperwork before the official person gets here. Like, we had a hierarchy. We don't have that for a lot of our languages up here.
Yeah, for sure. It's a very great question.
Okay.
Another piece of all of this, so this is a Medicare Part B benefit. And so for those of you who have done work on behavioral health integration or chronic care management, there is generally a co-insurance paid by the member So let's pretend that the service costs $80 or $100, let's do it easy. $100 to deliver chronic care management. The patient is responsible for 20% of that. So they would have a charge of $20 each month that they receive the service. That's been a deal breaker in a lot of places for chronic care management for folks. Why we're talking about this today in the context of dual eligibles. They don't have, they're waived from the copay. The other group that's waived from the copay right now are Medicare beneficiaries who are participating in ACO REACH. So accountable care organizations that are participating in the REACH model, because it's a total cost of care model. The CMS has said we'll waive that cost, that copay. But you have to get verbal consent like you do for chronic care management or BHI referrals. The clinician has to get the patient to verbally or written consent that I am willing to accept you giving my name to someone to talk to me about this, right? So it's not, you're not acting around somebody who wouldn't want it yourself, right? So just making a note that for those of you in the clinic world who may be thinking about operationalizing this, it will be very similar to what you've been doing for chronic care management. And the other big thing to carry away with that is there can be no crossover or duplication of other services. So if you are doing chronic care management with somebody for their 20 minutes a month, you can offer this as a wraparound. You just have to have very bright lines in the documentation that you're not duplicating. Right? All right. Key concepts of the patient illness navigation. So this can be done in-house. It can also be done with a subcontract to a community-based organization to help address. The interesting piece of this one is it does not require a social determinant of health assessment, but it's certified or trained auxiliary personnel under the direction of a billing practitioner. So like a CHW, patient navigator, patient educator, whatever, that work with somebody with serious high-risk disease that's expected to last for more than 3 months. Oftentimes what triggers this are people who had a precipitating event, and they're being discharged from the hospital, they had a massive heart attack, their life just tilted on its axis. And so they're gonna need a lot of care, you're gonna be in treatment for this heart disease for the rest of their lives. And so they need some extra handhold to get used to mended hearts, to get to the cardiologist, to understand the diet, to understand the medications. And so, this is an opportunity to provide service for those. And examples of the conduct disease states are dementia. Just think about some of the folks that you have dementia and how much help and work could be offered to help navigate them. Diabetes, cancer is another big one. The folks that I've worked with in cancer services are really excited about this because if particularly you're a rural person, then you've got to go to Phoenix for treatment, or you don't know about being in a clinical trial. There's somebody there who can help guide you through all of that, help make sure that you've got the appointments that you need, understanding that you need to tell somebody about your medication reconciliation because things have changed. So there's a lot of opportunity in that arena for patient navigation. All right, and so the targeted health-related social needs that CMS, we're going from social determinants of health to the needs to the assessment. And these are the things that they're really focused on that they think is going to make the difference in helping somebody manage their disease better. Yes, ma'am.
And so on the last slide, it said seriously mental illness. So SMI is very specific. It's only SMI or so not other aspects of behavioral health.
There's peer support, like for substance use.
Yeah, or depression.
Yeah.
But not that intense one you were talking about. That's just SMI.
Correct. As I understand it.
Okay.
And I will say to y'all, this as I'll say it again, I keep saying it, this is an evolutionary process. It's iterative. It's like we're going with it and it can change tomorrow. I've been involved with a group in Buffalo, New York, who is what's called a community care hub. We're gonna talk very little bit about that later, but they are part of a pilot project through the Agency for Community Living, so aging services at the national level. Has been working in this space for a very long time. They've been the big advocates actually for getting CMS to take CHW seriously and make this work. So I'm working on a 20 community pilot, and Buffalo is one of them, that is trying to figure out how do we operationalize this between a hospital, an ACO, a health plan, and patients. And so being very strategic, methodical about how all of this is going to roll out. So we've been in months of training, negotiations, talking about all of this. So what I tell you now, next month, and certainly probably, you know, after the first of the year. But I think what I'm trying to give you today is the general concepts, and specifics will meet themselves out later. But these are the identified areas that they're looking for the opportunity for some intervention. Okay, so health literacy, limited self-disease management skills, which we all run into, food insecurity, transportation insecurity, access to medication, housing insecurity, and unreliable public utilities. And so we narrowed that all down to say this is what we think it's gonna manage. I'm not gonna spend a lot of time reading these to you, but it's sort of conceptually the idea around how health-related social need can impact someone's access and management for diabetes. So food insecurity can have negative impact on their dietary ability to make dietary changes here to a good diet. Housing insecurity, they need a refrigerator to store their food. They need to know where they're going to be resting their head. They, you know, housing insecurity is, and we'll get into some more detail there. Transportation, it's the same definition pretty much for all of them. Can they get their medication? Can they get to their appointments? Utility interruption. If you're diabetic, it becomes very important that you have refrigeration. That you, some disease states like heart disease, very similar, for climate control. It becomes, you know, if you have a heart disease, you can't be living in a one-room apartment with no ventilation and the apartment's 98 degrees. You just can't do that and expect that somebody's going to be well. Same thing with COPD, air quality in a room, it matters. If you're living in shabby housing that's roach infested and whatnot, that's not gonna help. So you can study on those later. All right, so there is an approved screening tool that CMS is looking for you to use. You are allowed to use the Prepare tool. You're also allowed to use the North Carolina tool that came out of their 1115 waiver. But the one they're really pushing everybody to try to use is the one they developed out of their Accountable Health Communities Initiative. And they're looking at 10 key questions. And so in your handouts, you should have a copy of the ACH tool. It says CMS at the top of it. That's the detail of the questions that are there. And so, like I said, there's 10 key questions that they're looking for the clinician to assess, right? I'm going to talk about that a bit. Her question was, does it have to be a clinician? It has a CHW can do the screening in the clinic. It's a screening at that point. It becomes an assessment and becomes billable and actionable when the clinician tests it. They review it with the patient and then they bring the data into the electronic medical.
And as you're going along, if you have a sense of how it compares to prepare, that would be interesting, because I think a lot of people are very about the.
Yeah, I do, I have not done a side by side comparison. Many people are taking the conversion. And prepare is a whole lot more. You can do all the deeper screening that you want. But this is where most clinicians are gonna go. This is where you're going. Okay, like I said, you can ask questions about employment, you can ask questions about expertise on the deeper assessment. But this is what you're looking for. So remember those areas that they know scientifically, so we can address these things. We can have an impact on some of these outcomes.
Yeah.
Okay, so, some detail, just so you can see it. Relative to housing security, what's your living situation today? Have a steady place to live, no issue. Have a place to live today, but I'm worried about losing it in the future. If you check that, they've got a deficiency, they've got a need right there. I don't have a steady place to live. Surfing couches, whatever, that's housing insecurity. Question number 5, think about the place that you live. Do you have problems with any of the following? Passing bugs, mold, lead paint, and pipes.
And we're welcome.
You get the idea. It only takes one check mark on one of those questions, and that is a need that is going to identify. Food security. Again, it's often true that within the last 12 months, I was worried that my food wouldn't last for the month. Bingo. You're diabetic and you don't know where your food's coming from, and you don't know if it's good food. Bingo, we need to get after that. Transportation security. Again, pretty straightforward. We got in the way of my ability to get to work, appointments, medication, grocery, and then utilities system. And then the last one is safety. I spent a lot of time on this one. There's a score that goes with it. If you score, what is it, between 4 to 20, 11 and a higher, that's an actionable item. Y'all are probably familiar with that, and your facilities have policies and procedures to address that. So then we get into Z codes. So there's a handout as well that you have relative to the Z codes. It's a 2-sided page. This particular one that you have as a handout has not been updated to my knowledge by CMS. Those it's like 2021. It was put out, but not much has changed. For those of you in the clinic environment, you've been probably collecting, if you're an FQHC, you've been banged on forever, but collect the Z codes. The rest of the clinical world out there, regular physicians, primary care docs have sketchy at best. And CMS is now pushing them to have to do this. ACOs now have to do this. ACOs have to have an equity. It's coming. It's all part of that value-based contracting. But most electronic medical records now have this ability. And you will translate those health-related social needs into Z codes. And the Z codes have to be brought into the medical record. So that's where the assessment becomes part of the official record. It starts to build the profile around the diabetic diagnosis with housing insecurity. This is how we capture the structured data to be able to run the reports. To look at it. Right, right. Just like there's no money attached to diabetic diagnosis, right? In an HCC code, but you're building that profile, you're changing the there.
That was my question, and you're like,
Yeah. Okay. There's CBT. Yeah. So there is a table. This is a copy of a page from chapter 21 that has all the related social details. And when you get the slides, that should be a live deck, a live link in the slide deck.
No, yeah.
Be able to get to it, but just by way of example, these are Z codes that would be related to housing and security. I'm not gonna spend a lot of time going through these. You'll see a lot of them are repeats, like lab column, person without housing, they have without adequate housing, Z 5910, they don't have air conditioning, Z 911, temperature 11, heating 11. There's a lot of repetition. Related to food insecurity, there's really two codes. That's it. Okay, 41, 48. And then transportation is easy. It's the same one for all of them. So then by way of example, if you had question 6 on the AHC tool, within the last 12 months, you were worried that your food would run out before you got money to buy more or got more, and you answered that question often, then these two Z codes is what would go into the record. Potentially, depending on what the interview, how it went. Does that make sense to you? Okay. There's another example. Housing insecurities. I have a place to live today, but I'm worried about losing it. And there's actually there's a often or other in that housing instability area. And in her case, you know, maybe it was the refrigerator doesn't work or the oven doesn't. So can she prepare food? So there's a risk of homelessness if she's worried about losing her housing. That is insecurity in and of itself. And then it's inadequate housing because maybe she doesn't have air conditioning, she doesn't have stove, she doesn't have really food. Make sense?
Yeah.
So, if we-
This is just me, but I think at some point it might be good to stop and kind of revisit how this is applicable to CHW. Because there's a lot of people who don't work in clinical settings.
I understand that, but they have to understand this, to understand how you fit into the picture.
It's a lot for them.
I know.
I wonder if some people are getting lost.
Well, and we're gonna circle back around that. But
Yeah,
I'm
and-
happy to take questions. We're about to break.
Yeah, and also we discussed it earlier with some folks that we're gonna take a lot of questions from this presentation, and we can circle back in the following meeting to see how can we apply this information, because we understand that it's a lot and it's
Yeah,
from different perspectives, but yeah. So,
again, just trying to give you context.
And like yesterday, for example, we have these two ladies presenting and they're willing to do one-on-one presentations. We can do that the same because, for example, it's not my department right now, but I'm gonna pass this information to my boss and she reach out or do the questions to you or.
I can make a living out of just doing this all day. Let's revisit, I mean, I want to support you in that, so we'll figure out something. You know, maybe we do another one, now that you'll heard it, you'll say, I don't want any of that crap, but I want this.
We'll probably doing a team call, probably doing a team call. We can take 2 to 3 questions and then pass the information to.
I think Erica's comment is really, really good because you have a situation where some networks for today you're representing Chiricahua and you're a community outreach CHW person, and you know the whole system, but for this to really percolate and be applied, you would need some of your population health and clinical decision makers.
Yeah.
Like you would need Emily and probably your CFO or CMO or something to be a part of this, right? So
Yeah, because, yeah, it's a great example because my program is outreach.
Yes.
Community health workers, but we also have integrated community and they are in charge of all of this. So I'm gonna pass this information, but I know she's gonna have more questions. And I don't think that if I think everything correct, so I will let.
Yeah.
And for the most part, it this helps. It for the most part, For us in SBHCs, a lot of this isn't new. And we've probably already been versed in a lot of this, so your people in that population have probably already. Yeah, because this is what we live off of.
And I hear some of these, so I get it. but-
Yeah.
Yeah.
Yes. Yes, absolutely, absolutely. But remember, I was talking about clinically integrated and socially integrated. So she's talking about mastery of the clinical integration. That's the clinical team knows all about that stuff. Now it's time to take it to the next level, and as we use our CHWs and do that social care delivery in a really.
Yeah, and that's part, like, for example, I have been using the repair for like, I think more than a year right now. We're able to include it in the EHR next gen system, so we're part of the collection, the data collection, so we send it to the provider and the provider charts the CHO integrated team to follow up on that. So I'm used to this conversation, but I would like to know more about billing and all of that, but like you said, it's not like, so yeah, it's a great.
But it kind of is,
Yeah.
because what she's talking about is, and I'm sorry, Anna.
No, I love it.
That health and social services model is there. So,
Yeah.
for example, within the last year, within my department, we have a housing coordinator now that's focusing on those particular aspects of social determinants of health. There are patients that are coming in that are identified, and that was one of the things that got checked out. Hey, this patient is having housing issues, let's get them to the housing specialist and get that goal, right? And then the same thing with all the other social services that are affecting that, like transportation, like paying for medications, like paying their utility bills, those types of things too. So,
Yeah.
yeah.
Yeah,
It's part of it, yeah.
but, and there's organizations here, there's CEOs like HRSA, PAC, companies, so they don't have a political component, but they connect with organizations that do, so that's the other link that I think is a network. With this resource that Anna is bringing, figuring out a way that they can benefit, how can they hook into that system? And I know like Campesinos, with the relationship with Arizona Complete Health, that was one way to do it. There's different, yeah.
Yeah, and we're gonna talk about it. At the end, we're gonna wrap this all up, and part of it is, what do you want RAzCHOW to do? How can RAzCHOW support this? Because it's not limited. All right, so before we go to a break, I think this is sort of my last slide, to talk about, just a reminder, bringing it all together. We talked about documentation was gonna be really important. You can't duplicate things. You gotta make sure that things are important. So, big things are that the Z codes get into the problem list, that there is a care, everybody's got a care plan now, but now if they've got health related social need, there has to be a plan around that has to be in the record, available for.
Excuse me, Joel, I think it's a lot of background noise, and for some persons, it's difficult to listen to on. So.
And
can
the
you
owl
please-
picks up
Yeah, and the owl
Oh, yeah.
keeps moving around, so please, we're just about to break. Thank you.
Thanks. Have their monthly encounter notes, so there has to be documentation and communication between the clinical team and the social care team. Meetings, if there were meetings to talk about, like sometimes monthly meeting, case management, meeting, whatever that is, it needs to be documented. And then there's reevaluation of the patient. So within like no sooner than 6 months, but within a year, they need to be reassessed to see, have we had an impact on, do they still have these needs? Maybe we've had a great team with housing, their housing issue has been resolved. And then,
So if the CHW brought into providing services, are their encounter notes?
yes,
Are required, they're part of the, yes, they are part of the documentation.
however, the billing coder defines that, what do they feel like they need to put into the record? But more is better. So a lot of people around the country are struggling with Unite Us and Contexture. How do we pull in those case notes in a way that are meaningful into the electronic medical record. All right. And this again is the carry away. I was heading down there and you beat me to it, is that there are third-party contracts for community-based organizations that are allowed by this. So you as CBOs, what we're trying to do is position you to be able to go out and negotiate contracts with other clinicians to be able to deliver these services that you do so well. So let me be clear, this is different from what happens with Medicaid right now. Medicaid, as CBO, if you go through all the hoops in the process, you can actually bill directly in Medicaid at the state, as I understand it. You cannot, as a CBO, bill Medicare. You have to go through a clinician,
Right.
and the clinician contracts with you to deliver the service, okay?
Or how could it
And
be?
it can be a help, yes, we'll talk about it. The CHI and PIN services to be performed by the staff provided by the community-based organization, and the documentation is. And again, to what I said, the biller has to review and verify the documentation. It's really on them, right? They're gonna submit, the clinic is gonna submit the claim to CMS. And if I were the clinic, I would pay the CBO until that claim came back and cleared. And that's why we're gonna be talking a little bit about how to do some really small scale pilot to test, to see, is our thinking about the way that we're documenting this and adding something that applies. All right, so any questions before we get a break? Yes.
I just wanted to say, Blanca and Eva from Circles of Peace, they wanted to let you know they had to leave, that their roof leaked in Nogales and their office is flooded.
Oh,
So they must have had a good storm, but
Let's hear.
they had they wanted to get to the CBO part, but they had to go. So anyways.
yeah, it was all over the news yesterday.
Oh, yeah.
Yeah.
So they got a call and.
Oh, my
they were
goodness.
kind of Waiting and I said, so just go, you know, yeah.
Oh, yeah, no, we got a lot more to go.
But they said, thank you very much, and they're listening, and they wanted to figure out that, community-based organization connection part. So they have to leave.
Any other questions? Oh, look, Alex is the man. He's got the slide deck. All right. So, 10-minute break, is that what we want to do, Arturo?
Yes, we can do that, definitely.
So we're deviating from the agenda.
What's that?
9:38, okay, it's until 10, the break.
Break
Oh,
is
yeah.
at 10.
Uh-huh.
So we're going to break now for
15 minutes?
so the other thing that worries me is anyone that needs to check out that hasn't checked out.
It's a good reminder. 11.
It's 11.
11, but we're deviating from the.
Patty will get the chairwoman flexibility of her.
So if you have not checked out of your room, this is a good opportunity to do it because we won't have another break at all. So,
When are we reaching?
we have 15 minutes.
15 minutes, yeah.
So we'll get back together. If not up, 10. Okay, so everybody online. We can-
Yeah, I'm gonna-
Everybody break. We'll get some coffee. We'll be back in 5 minutes.
Thank you, Anne.
Thank you.
Yes, they're-
Yeah, they're showing the streets flooded and power outages in different areas in downtown Nogales. I saw like, Nogales International, like one of those alerts. That's what I saw.
I did online with them. I did it until.
Yeah.
Wow, yeah, because I guess Sunday was a big one too, so I'm missing all this, so I think there's not a lot of.
Tucson had a lot of it,
Yes,
like around where we're back.
my house basically said that.
Yeah.
It's a little scary.
Generations, the sample clinic workflow, case study, and then the draft pilot process, and we're gonna go over that capacity survey tool, so.
Yeah, I'll let you ask, not going, whenever you're ready to start.
And please let us know if you don't have a copy yet of the presentation, you take notes, okay.
Okay. So here we go. You also have this as a handout, I believe, a separate handout, so you can read it and it's not microscopic. But this is a sort of a sample workflow of what this would look kind of from a big picture. And I'm not gonna necessarily read this to you. It should be pretty logical. You got a beneficiary who comes in. They do the assessment, and I'm gonna keep stressing the word assessment versus training. It's got to be an assessment in order to build code. You've identified a need. The provider updates the problem list. We talked about that. You can bring it in with the Z code into the record. Person-centered assessment. So then they identify the need and want to refer it out to a CBO or a community care hub or somebody else to do this work. So then you're the CBO, you can go in and do a deeper assessment of what's happening with this patient, because we all kind of know what it looks like.
They say that
You can do a deeper assessment to determine what else they may need that will help inform you as the CBO in the development of that portion of the care plan. Okay, so you know a lot more as you do that interview with them about the gory details of what their housing looks like, of what their transportation issues are. You know, they live 2 miles off the main road on the dirt roads. They've got nobody to call on in the neighborhood, blah, blah, blah. You develop the action plan, care plan, and CHI services delivered. And then you work with reporting that information. You're working with the clinician to report to them how things are going. You're sort of their boots on the ground to be able to go into the homes and work with them. Again, I will stress that the services that you are rendering are navigation and education services. You are not buying them groceries, you are not. So thinking about they're food insecure. I know this is a pipe dream, but I'll just say it. This is my dream. So they're food insecure. You spend time getting them enrolled with SNAP. Okay, you can be paid for the time it takes for you to do that work. They don't have a computer, you know, you get with them, walk them through that process. And so now they got a SNAP card, but they got no transportation to get to the grocery store or whatever. So you can work with the food banks to have grocery boxes delivered. That is acceptable. You're not buying the grocery box, nobody's paying for it, but you are coordinating all of that. You could get them enrolled at Walmart with Instacart. If Walmart will deliver to their door where they live, or to a drop-off site. I know that's happened in a lot of rural communities. On Tuesdays, Walmart will deliver groceries for this neighborhood to this place and people can come and pick it up. So that, all of that work, if you have to negotiate with Walmart to set that up for that community, that is time that is allowed and available, okay? You do your reporting monthly, you have to do it monthly, okay? This isn't something you sit on and do like quarterly or every 6 months. You have to have an infrastructure in the organization that allows you to do this on a regular basis. There's closed loop reporting, so they're sending you referrals and sending you information. You're reciprocally going to close the loop and say, here's what we did this month, here's how it went. And then keep at that cycle as needed. You don't, there's nothing prescribed that says you have to work with somebody 90 minutes a month or 60 minutes a month. It's what they need over the course. You may resolve an issue in 3 months, be able to close the referral and say to the physician, you know, their housing issue is all good until you go back and you reassess them in 6 months and the wheels have come off the bus, well, then we'll go back and we'll try and stabilize them again. Make sense?
So, and you said there is no max you available units with these.
No, that is the joy of this. This is real money. This isn't like chronic care management. We capped it to a set fee for 20 minutes of service delivery a month. We're going to talk a little bit about that. We'll get to that in a little bit more detail. So sample list of services of the types of things that are eligible for reimbursement for CHI services. And you will see striking similarities between that and the patient illness navigation services list. And this is not, you know, this is just an example. There are other buckets of things that could fit into this, but this is the general sample of the types of services. So hopefully for those of you who are in the business of being a CHW, this looks all very familiar. Oh yeah, I do that. I do that. Yeah. So these should be all in your wheelhouse for the most part. Okay. And here are the navigation. And the main difference there has to do with the fact that they've got a disease state. And so leveraging knowledge about a disease state, about a disease condition, educate them to understand what's going on. What's the other big one? Clinical trials may be something that you can be a navigator or a facilitator to getting someone to, but all in all, the services are very similar. Navigate people through the people. All right, so the services. Drum roll. How much do we get paid? Yeah, all right. So the clinic, it gets better, trust me, this is a small potatoes, but this is for the assessment, all right? So you can screen till the cows come home, but until it gets brought into the electronic medical record with the Z code, then you can bill the G0136. Is my understanding FQs can do this? Standalone, you can do this. Usually it's done on a transition of care visit, to Susan's point, like an annual wellness visit for Medicare beneficiary. That's the prime time to be able to do it. A regular, evaluation and management visit, not an acute visit, not if I'm coming to you because I have bronchitis. That is not the time to have this conversation with me and do that. But if I'm coming to you for my regular diabetes A1C discussion and re-up on my checking in on my medication, those are the things that you get in. So then here's the CHI number. So community-based organizations who may or may not work with FQHCs, pay attention to these other codes, because if you're gonna work with somebody other than an FQ, these higher rates also apply. They allow you to bill the first 60 minutes, and these are national average rates, okay? They fluctuate by state, by geography. I'll be honest, we're rural. We're generally in the Medicare wage index floor. Reimbursement. The $80.56 is the national average for the 60 minutes. You get 1 60-minute block in a month. And then you can add 30-minute units on top of that. You don't do another 60 and another 60 and another 60. You do 60 plus 30 plus 30 plus 30 plus 30. Okay. That adds up to real money. You have to be careful in the documentation. Put this into action in your conversation later, but now raise your hand if you think that's reasonable and more than what you've been being paid right now for delivering CHW services.
Like,
Right?
that's.
Yes, why not? It's true.
My question is, for example, we're right now as a clinic, charging for annual wellness for Medicare patients. So we're gonna be, with this, we're gonna be able to charge also if the CSW is part of bringing that patient to a clinic.
No, you're not gonna transport them. No, you can arrange transportation,
Okay,
but you cannot drive them.
okay,
That gets into that buying the food, buying the transportation.
okay,
Okay, it's not the delivery of the intervention itself.
okay.
But you have to constantly check yourselves because that's different than how Medicaid operates. In a lot of states.
If that's, just to put it like in very simple terms, let's say we are non-community based organization. RAzCHOW is our medical. Can you give us an example of how that process would walk through, like me, CHW? I make connection with the patient, right? All right, and I'll be doing like the assessment portion of that, or,
You don't have to.
okay,
My recommendation would be, you probably want to. The way it works in the clinic is it's usually pretty, I mean, in truth. In the clinic, a lot of times people will give somebody a tablet and they just check the answers. The nurse or somebody will bring them into the room. They ask them some questions and maybe they'll get an in-depth interview, maybe they won't.
they will.
But we know they have a health-related social need that needs to be addressed, and I've talked to the patient enough, she's troubled enough, we can't manage her care very well. So let's try with CHW. So I might, if you're in my clinic, I might actually bring you into the clinic to talk with the patient and say, hey, this is Mary. She's I'd like for her to work with you to help you, try and understand your medications better and yada, yada, yada. Or I'd like to refer you to Mary, who works with our organization, and she's gonna call you tomorrow or the next day, set up an interview. To which then you would do the assessment and get deeper, because you'll have to negotiate. If you're an outside referral from the physician's office, how much information are they gonna give you? Are they just gonna give you, like what we saw yesterday with Contexture, they have housing insecurity? You're gonna need to know more about that than just that they're housing insecure. So I would do an assessment, I would do another screening with them. Being mindful, trauma informed, you don't wanna re-traumatize them if there's some aspect of that interview. But you also wanna stay in your lane and stay with those 10 questions.
Yes. And then it goes back to the.
Eventually, you would put that, you would use that information to develop your care plan. And that care plan with that survey and assessment would go back to the clinician. Here's what I recommend that we do, and in my mind, maybe mid-month, you've done the assessment. She is gonna take some time to work through. So here's what I would recommend that we do. Talk to the nurse or the case manager at the doctor's office. I think that sounds good. And you're off to the races to do whatever you need to do. Do your documentation. And for that month, and just plan to continue to do what you need to do for. We just have to be in touch with them on a regular basis.
Yes.
Team ball, right?
Yeah.
Care coordination is all about lots of people.
Yeah, just like how it would look on the senior side.
And that's just one idea of how it would work. I mean, it's really gonna be up to y'all individually, how you're gonna put this together with your partners. All right, and then the patient illness navigation, surprise, surprise, the rates are the same. Okay. All right, then, and then for rural health clinics and FQHCs, we're in a little bit of a different bucket. You got this GO 511 code that can be filled multiple times in a single month for a variety of different services. So we got chronic care management, we got behavioral health integration, we got patient monitoring, telehealth, CHI, and support. They all have codes. You can bill for them. You just need to be sure that your documentation proves that you are not double dipping. Okay, you're not counting your chronic care management 20 minutes in the hour that you're also spending with CHI. Or patient illness coverage. And this slide is in your deck. So you good? Kind of got that in your head? Now we're gonna go to the financial model. All right, so what we were talking about before. We've kind of got CBOs and CHWs, you got two options here. One is what a lot of FQHCs in the country are doing. They're just building it in-house. They think they got this wrapped. I want to challenge you to say that I doubt that you can do all of this. That you might find that you've got some pretty good partners out in the community that you should think about engaging for certain levels of service for this one. That is up to you. So in-house, you've got FQHCs that can build or are thinking about building this, and some hospitals. Big hospitals, they really think they can do it all. Right? So nobody's gonna tell me anything. Yes, ma'am.
A question for the CBOs, besides the CW certification, do they need any other certification to be able to partnership with hospitals and private clinics?
No, according to CMS, as long as you're a card carrying certified CHW, you're good to go. Need to be current.
I like that, card carrying.
You need to be certified.
They are not eligible.
If they are, you just have to have documentation that it's a credible training. And it also means that the federal government is after that state's backside to get going on. Okay, sorry, yeah. So then, you've got the in-house piece, but then you've got this whole outsourced. Which would be contracting, a clinic or a hospital contracting with you to do the work. So you go to CBO, has three options. Remember, you're a specialist. People want to come to you for services. So you could work with primary care, like Dr. Jones down the street with, ABC Family Medicine. They don't have to be an FQHC. They can be a primary care practice that has, and all of them have Medicare fee-for-service dual eligible beneficiaries, almost all of them do. You could work with an ACO. We were talking earlier about Banner Health. There's a huge ACO in Arizona. There are several others. They're all dealing with Medicare fee-for-service beneficiaries, and that is a target for you. Hospitals and payers are going to be interesting people for you CBOs to know and work with in the future. We'll get back to that in a little bit. So here's how the money could sort of flow. Don't shoot me, we'll just basic numbers out. It's just to give you an idea of how the math might work. Okay, so you have one FTE community health worker. This is if you were building it in-house, you're an FQHC. And these are rates. Hourly wage is $20 an hour, it's 35-hour work week, annual salary of about $36,400 for the year. You have one FTE CHW that supports a caseload of X. I don't know what kind of the average out there is, somewhere between 30 and 60, depending on the type of work that you're doing. I spitballed in the mid-40. 60% time is estimated right now in the modeling that people are using nationally. That 60% of your time in that full time would be actively in billable service time. 40% of your time is in documentation or other administrative things, right? We all have administrative things. We're not always 100% billed. So with that in mind, you've got 84 hours a month that are billable and 40 or 56 hours a month that are administrative. So if we use the G511 7168 for 60 minutes, you've got 84 hours for the CHW navigator times 7168 brings in 6,000 and change in revenue for that particular month. So if your salary for the month with fringe, your staff cost is 39. You're bringing in 6,000, that gives you a net revenue, a profit, if you will, of 2,000 and change, which allows you to help support the position in the form of travel time, cell phones, other things. Because your fringe, just to be clear, is what's covering your insurance and all of those things, right? So net annual revenue is around $25,000 per CHW to have available for operations to support the program. So again, you have to take your own numbers and look at that. See if it makes financial sense to your organization. Now, here's another one. If you're a CBO who is outsourced, so toward the back of you, same logic. And I did this model again, if you were subcontracting with an FQHC, your revenue potential would be more if you use the $80 an hour, which is that revenue. But the general rule of thumb that CMS, when they modeled this out, expected that the clinic would retain 10% of that $71 for their administration, for their billing encoder and to submit the claim and issue the check to you. But that 90% of the remainder of that billable hour would go to the CBO to do their work. So the amount of revenue that you would make is slightly skinny down to 17,600 as opposed to 24,000 a year, 25,000. But you get the idea. All right. So, Arturo has a copy of a workbook that we have available from the Georgia Health Policy Center to help you with business planning, to try and figure out, plug in numbers and real costs, to try and figure out for yourselves, does this make sense? The one thing I need to make sure is that you have the Excel spreadsheet, which is really the magic in this. This is like a 10-page document or something, with a lot of the value of what's going on with health and CHW work. But
Yeah. You all have the Excel spreadsheet.
no, that's not that.
That's not that
No, there's a spreadsheet, an Excel file that goes, we talk about
Which-
both of
okay,
that.
yeah.
That goes with it.
Yes,
That you can plug in numbers and play with it to, it also has a lot of stuff to take to your leadership or to partners to try and make those block-headed primary care physicians or CMOs at the hospital or the plans, to try and engage them, to make the case of the value of the work that you're doing. So there's a lot in there. And Arturo, we're gonna be working with him and that RAzCHOW team to be able to help provide you that support, to help you work through that stuff.
Yeah.
All right, so, everybody good with that? Hang on, because we're getting there.
Yeah, I was just gonna say, you mentioned making the case, and I think that's so important because I'm not familiar with that worksheet, but if it's a worksheet where you can put examples in, like based on what you pay someone, and, or say you wanna start from scratch, create some CHW positions, but you have to start somewhere, like you don't have salary yet, you wanna convince the leadership in the organization that if we create these positions, that they'll pay for themselves over a certain amount of time, and I think it's really great. I hope that this will be useful for people. Yeah.
Yeah, just keep at it, right?
Very
That's
cool.
its message.
Yeah.
And I know I'm drowning some of you in this information the very first time. It's okay. You will survive. You will have some kernels that you can hang on to, and you will come back to it again and again. You need to hear this stuff over and over and over. I mean, I've been doing this for over a year, really deeply studying this, and I find new things all the time. It's just, you gotta keep at it, right? All right, so contracting and billing considerations. So you're gonna be a CBO, and you're gonna go out, you're gonna contract with the clinic, you're gonna contract with payers, you're gonna contract with a, whatever that third bucket was, the documentation is absolutely critical to getting paid. Okay, you heard me say earlier, I'm the clinician, I'm the hospital, I'm the payer, I'm the FQHC. I am not going to pay you until my claim gets paid. Okay? So that means y'all are a team. Getting that documentation together and telling that story to CMS that we did a really good job with this and you need to pay us every penny. Yes. All right, so again, you saw this before, but now a reminder, now that we've been through a lot more stuff. Z codes have to be in the problem list. There has to be a care plan, right? So the clinic has a care plan, but now you, with all of your deep dive and all your expertise as the community health specialist, you are going to help develop an even better rounder care plan related to their food, their transportation, their medication adherence. You're gonna help document the monthly notes. You're gonna participate virtually or in person, however, you're gonna be touching base with those clinicians to tell the story, and it's gonna be documented in some form of a report. Y'all negotiate that with the clinician, whether you're gonna do it, they're gonna do it, it's gotta be there. And then, reevaluate the documentation, eventually reassessing. The clinic has to eventually reassess that patient. Okay, has to be assessed. You can survey, they have to assess, and it needs to be in the record. All right, so documentation considerations, just a little bit more time, detail on this. So just like chronic care management, you guys don't know about this, but clinicians do. It's 20 minutes a month that you get paid for, and you have to keep time on how much you have spent. And so electronic medical records, a lot of, I don't know if any of you are actually using any kind of reporting platform like an EHR in your community health work CBOs. One of the things that we'll need to find out from Contexture is, can they capture the time information on the time you put into a referral? But somewhere you're gonna need to say, you know, I started talking to Lucia at 10:02 on Tuesday, and the conversation lasted, I look at my phone, I was on the phone for 12 minutes with her. But then I'm digging down into it and I'm working another 45 minutes trying to make that connection for her to get the food box delivered. So that time gets added in. So you're keeping a time tracking sheet for, and many of the records, like electronic medical records on the clinical side, they do, and people love it or hate it, whatever their tool is, how it tracks the time. But you will have to figure out the way to do that and keep that documentation. If nothing else, you keep it in an Excel spreadsheet, or you keep it on a piece of paper and you convert it into an Excel spreadsheet that then becomes part of the record. But you get a total time for each encounter that you have on behalf of that person, and then the aggregate time for the month. Right? And remembering that things come in 60 and 30-minute bundles. So if you do an hour and 18 minutes in a month, find 12 more minutes to spend with Lucia. Okay? Or you're out for that 30 extra minutes. And you can't carry it to the next month. All right? So assessment completed and updated, patient consent is obtained. That should be the clinician's responsibility to do that. But you both collectively need to make sure it's done. Z codes in the problem list. You're documenting the link between the health-related social need and how the patient is treated. So that is a clinical, again, they need to tie to it, that they need you, the CBO, to do these things to help this diabetic better manage their care. The updated care plan is in the record, so your information and input has been ingested into that profile. Encounter notes are sufficient for the audit. That will be the responsibility of the coder or biller on the clinic side. Do we think we have a good case? That if somebody comes in and wants to audit us, we go to bat, it'll stand up. Meetings between the CBO and the clinic are documented, so when y'all get together on any kind of regular basis to talk, it's in there. And document that services are not overlapping. Okay, and there may be other things. You can always put more in. These are a lot of the absolute must-haves in order to meet the threshold. Yes, sir.
I know in the state of Arizona, a lot of the health education is face to face. Do you know if telehealth is considered face to face? No.
Especially here in a.
Yeah, that's a problem we're having because a lot of our patients live like 30-40 miles away
Yeah.
from our site.
Yeah, we'll get to that.
Oh.
Travel time doesn't count.
Yeah.
And that's one that we need to make the case for, that
Yeah.
from Medicare, hello, rural. You need to get with the program on this, but you can work with them telephonically
Mhm.
on some of it.
Okay.
What CMS sort of said is, well, what I think, Chad, is you ought to just like set up a lot of meetings in Tuba City and drive out there and just do all of it in a day. Like, oh, come with me, CMS. Let's watch you do that. You show me how it's done. But that's the stuff we need to get collected so we can tell the story. I think Sachi's probably gonna fire me. From a billing perspective, for FQs, the G511, these are some ways that you can kind of combine things in a month, what you're doing. So you're doing chronic care management, you can provide 20 minutes of service around that, and then combine it with another thing like you're acutely ill and you've got patient illness navigation services that you want to add to it. So you would bill your 20 minutes for CCM, and then you would bill the additional time for patient illness navigation.
Can you remind me what RPM is?
Remote patient monitoring.
Okay.
Sorry. This is for my clinic people. I think they know what I'm talking about. But those are just examples of what we have.
Those are like combinations. Of
Yes.
Put a visit together.
Yes, have a billing like that. As long as you've got red lines around each one of those services and they meet the criteria, you can add on to it. Because again, your ISTs are not doing this other stuff. Your nursing staff or somebody, your behavioral health specialists are doing this stuff. Your community health specialists are doing something different. Okay. All right, so contracting ideas between healthcare and the CBO. You will need to develop a contract. Okay, this isn't something you just have a gentleman's agreement about. You need a contract for services between the clinic and the CBO. And I've seen it go both ways. The CBO can have the clinic, have the contract, it can be their contract with the clinic or vice versa. You just need to negotiate. And things that you want to think about considering for exclusion are recitals. That's legally is for, if you've ever seen a contract, all the whereases sort of lays out. Whereas CMS has made these codes available, and whereas we are a provider known to serve this region with great quality, and whereas we are resolved that we will enter into this agreement. And so it just sort of gives the context for what you're doing. You need to, in the language of the contract, be sure that there is recognition of the existence of executed business associate agreements, if as needed, data use agreements. They're not in here. It's the acknowledgement that we agree that we will maintain current BAAs and DUAs. That we will, adhere to all of the rules around confidentiality. Yes, ma'am.
I've seen the template, agreement that Freeman's.
Yes.
Came up with. Do you think, you think it's a?
Yeah, and it's gonna be all up to everybody's lawyers to get after it.
It
So
took you like a good,
it's
look
just
at it.
starting to get out. And so like in Buffalo, they just loaded it to the Catholic health system and their lawyers are all over it.
There.
So they've got a chew on it, but I think that is a great template. Yes. Yeah, and we can make sure that Arturo has that as a template. What the process is gonna be for enrolling beneficiaries. How care coordination of services will be delivered. It doesn't have to be in a lot of detail. But, and I can't say this enough to anybody, having agreements of service with people and negotiating doesn't have to be tense. When you do these things, you do them to ward off conflict. You want to make sure everybody's on the same page about how this whole project is going to roll. And you're gonna hit bumps in the road, particularly in the beginning. Oh, we didn't think about that. Or it's not working like that, so can we modify and amend the agreement? But the point is to sit down and agree. I'm a clinic and I'm going to give you these patients, or I am the CBO and I'm going to bring patients to you that I think do not have care and need service, and we want to manage that.
That was like an example that Betty did about identifying a woman and wanting to bring her to the clinical part. Right?
It can work any number of ways. It's just having that agreement. This is how we're gonna roll. So. What the cost and revenue allocation, so that whole 10%, if we're gonna keep 10%, we're gonna give you 90%, or we're gonna keep 20%, and give you 80%. Whatever that looks, it needs to be in writing, and I recommend that you attach a fee schedule that you've already worked out. Because I gave you a sample of what something might look like, but you need to know specifically with them, this is what they are gonna get reimbursed per hour, and this is what we're gonna get paid for every hour and every 30 minutes of service that we deliver. And then anything else your people, your lawyers want in there, how's documentation? You're gonna submit your reports by the 7th of the following month. They will agree, we know it takes 6 months for CMS to process, whatever. We agree to pay you within 6 months or whatever, so that you, on your end, have an idea of how this is supposed to flow. Always put in termination clauses, and you both need to subject yourselves to open audit with each other relative to the work that's being done in this program, which means they open their books to you, you open your books to them. But you also need to be ready, because if CMS comes down, you're both gonna be opening your books to that, right? All right, so CBOs, we talked a little bit about you've got some options, and I realize I have a typo on this next slide, I apologize. Jacob. So this is the group that sort of maintains accreditation and certification for hospitals. And they set requirements for hospitals starting in 2023. That hospitals have to have, that they need to start getting on board with this equity thing, a whole lot better than they were. So they are starting to develop population health management division in bigger hospital systems. And they have to designate that they've got somebody in their shop, even if they're a little critical access hospital, they have to have somebody who's responsible for dealing with disparities in that organization. They are required to assess for health-related social needs. And they need to provide information about community resources. So this is where Contexture, that's their sweet spot, is hospital customers, is to be able to tap into that and hand a patient on discharge. Here are places you can go to get food or whatever. The hospitals are really struggling, and it's gonna be interesting to see kind of where it all lands. They just sort of made this blanket rule. What hospitals have got to screen for social determinants of health. And I'm working with other grantees in critical access hospitals around the country that are like, what the heck? What do we do with them? I mean, we got,
That's why this came up a while ago. I was wondering, so you have supposedly all these assessments happening. Is there any training, publicly available training for providers on what they're supposed to do with the information they gather? Okay.
there's not, well, no,
I did some Google search.
Yeah.
Nothing, so.
not yet. And that's one of the big things we're taking back through the HDL learning community, the ECHO learning community, is to CMS, help us here. We did trainings years ago on race, ethnicity, and language. How does the front desk ask those questions? How do they record it? How do we do that? We've done that well yet. We still have more work to do. But I mean, we're just throwing people out there. There's another big conversation going around. Can health information exchanges serve as a repository for the assessments so that people, we don't have to assess them to death. Because these questions can be very traumatizing to an individual. And so you don't want to keep peppering them everywhere they go. So somebody just went into the hospital, they get discharged. Now they go to their primary care physician and they're gonna get asked a question. Physician says, yeah, you need to be referred to, Winchester Heights. And Winchester Heights is gonna ask them another set of questions. How can we do a better job of like sharing that information? Like early childhood development, aging and staging, instead of having to ask, let's just get the one and done in there. But that is not the tidy world we live in right now. People are being asked. I have a personal experience with my mother-in-law, who was just recently in the hospital, and she's 89 years old. And some guy comes in, dressed in scrubs, and starts asking her, like, so do you have enough money to pay for food? And he didn't introduce himself. There was no context. And she sort of like had enough presence and said, who the heck are you? And why should I tell you this? So to your point, there's training that needs to go to people to be asking these questions. The hospitals, like everybody else, they're struggling with how do we do this and do this right? But they are responsible for just giving them information in not about resources in the community, not like others who are actually going to be responsible for. There's got to be an intervention here, but there is an opportunity, I think, for partnership, particularly with your critical access hospitals as community-based organizations. Position yourselves as with the catcher's mitt to help them do a better job, because everybody wants to keep them from a repeat visit in the emergency room or a readmission. Everybody's got a vested interest in that. And it's the right thing for the patient, right? So, and then the facility has to develop a written action plan. I found this interesting. So community health planning, for those of you who do community health planning in our public health, like our Graham County Health Department, you're responsible for doing your community health assessments and your community health improvement plans. And we know that hospitals are being pushed to participate, in a lot of their charity care is now contingent on their donated service and addressing needs in the community. Sorry, that the hospitals are now charged with being able to demonstrate that if food insecurity is a big thing that keeps popping up on our assessments in our community, then we have to show that we are participating in finding solutions and addressing those issues in our community. Because we're a community benefit corporation. That's how you get charity care paid for at the hospital and how they get a tax write-off on it. So that's an opportunity for a different kind of a partnership in planning in the community. So hospitals are a place to go to get to know some people, have some conversations, get to know the equity officer who's in that facility. Then here's the big one, plans. So the plans get paid by CMS for the quality that they deliver, meeting certain metrics. And they are now charged with making sure that the physicians in their panel, so like when we all have our insurance plan and our primary care doctor is part of that panel, they need to make sure that that physician in his group or her group is doing screening. And they're going to be looking at the number of screenings that get done for people. And they're looking at these 3 domains, right? So food, housing, and transportation. And they're going to want to know that they've got numerators and denominators for those of you in the clinic world. We've got 1,000 patients. We screened 900 of them, and 640 had a health-related social need. So they're going to need to be able to report that. But then here's the kicker, is the individual needs to receive an intervention if they were screened positive within 1 month. So you've got a lot of primary care physicians out there working with plans who have a gun to their head, to get paid to make sure that those health-related social needs are followed up on. Right opportunity for CBOs to partner with primary care physicians in plans. So getting to know United, who's a big payer in your area, commercial payer?
She's sitting back there.
United. Yeah, so get to know the equity of, Blue Cross Blue Shield, who their equity officer is. And start, telling them, here's what we do. I think that is a role that RAzCHOW can play for you. Is starting to put together, we've got this band of CHWs. We think there's a there that we can help you meet your need. Yes, ma'am.
And so if the provider does not do an intervention within a month, they don't get paid. Is that?
It's not quite that stringent, but they're, right now, let's face it, they're all just trying to figure out how to actually screen somebody.
Yeah.
And give us 5 years and then we'll figure out what the next step is. It was like depression screening 1,000 years ago.
Yeah.
I'm not asking a depression screening because what if they're depressed? I don't know what to do with them. I don't want to. And now it's gone past depression screening to those who had a high score. Have we been able to lower that score within 6 months?
Okay.
It will come over time,
I see.
but this is where they're headed.
Is that the only, HEDIS SDoH measure, or there are many? Is there the only?
There are probably 2 or 3 more, I'm guessing. Okay, I'm gonna guess, yeah. Yeah, they're not trying to crush them. I mean, the first one was they had to have a point. And there's a whole thing with, the quality form and QF to, get them, accredited. A health equity accreditation. And all of this will play into the paperwork that in 2030 gets United certified as a accredited health equity. All right, so opportunity, that is my message here. You have opportunities to be tapped. And one opportunity that we're going to be talking about later today with RAzCHOW leadership is there is an emerging community care hub that is coming in Arizona. They just got funded, literally like kicking off this past month at the US Aging Conference. This Southwest Community Care Partners, where they are, we get a little technical on you for a minute, but for lack of a better term, their network of CBOs that come together in my language, an independent practice association. So you're all independent community-based organizations. You join this hub and they negotiate contracts with payers on your behalf. They work out the training that you need or work with you to do the training, do the billing, and take care of all that administrative ick that none of you knows about and really wants to know about, because I've been there and I've done that. It's not a free world, trying to work with payers on all of that. So they would take care of all of the billing. They would just send you the referral. You do your work. They give you the platform to report into that does the documentation the way that the primary care or hospital needs it done. You get paid. So that is, you are just getting one started to be stood up in Arizona. We're gonna be talking to them to see if there's a there.
I'm looking it up and I'm not finding.
You're not finding it, no. It took me a week. They're
Oh.
brand new. They're brand new and they are revamping their 501c3. So I don't want to say anything right now because they're not ready for prime time. But I'm sure it will come to you at your next quarterly meeting. There will be a report. Who pays for that? ACL is paying for them right now, agent. the
Administrative for
Agent
community living.
And
So-
US agent,
So they're starting this off with a grant.
correct.
Okay.
Correct. And what they're looking to do is try and making them self-sustaining because they'll need to engage a payer to work with them to do the work.
Yeah.
And that's the work I've been doing in Buffalo. I'm with a hub that's been around for 13 years. And they're in their 3rd round of doing this work. And they have 2 contracts with regional payers. They are just about to go into negotiation with Humana as the first national payer. And I don't think any of the national payers are yet in one of these arrangements as yet. Then they wouldn't be because the codes are new and everything's new. So, but that is another, I think, big opportunity for you as individual organizations, but a huge opportunity for RAzCHOW to consider.
To form or become part of that.
To be either, I mean, you can go out on your own, you can probably do both. You know, I mean, you could be a part of the hub and you could also, depending on how much you want to take on, you know, in the short term, go it on my own. While they're figuring it out, because it makes you that much smarter of a partner if you're gonna work with them. So, we're almost there, people. Everybody good? We're on the last leg. The baton has been handed. We're almost there. I might even be done. Putting it all together. So all of this stuff we just talked about, you have a copy on your desk and you will be able to read this in much more readable text. But it's a clinic workflow. So in detail, like that first little tier has to do with what the front office used to do in the clinic. The second one is what the clinical staff would do after you've roomed the patient. The third box is related to the delivery of, thank you, the delivery of the CHW services themselves. And the fourth box has to do with billing, and that's inflation, all right? But again, big pictures, some people have pictures. It's not definitive. It's just an example, and there's lots of them. I mean, we've got an example of transitions of care. So you've got somebody who's discharged from the hospital, primary care needs to see them within 5 to 7 or 10 days. You bring them in, here's what workflow would look like, but it's all generally. Alrighty. Now, here's a really rough logic model for what a primary care and community-based partnership might look like. I'm not going to spend any time on this, other than to say from a high level, it kind of paints the picture for you of components that would be in place, right? So your input, you got to do a screening, you got to have a referral network, you got to modify your workflows within primary care and within the community-based organization to be able to do this work. And you have to do staff education on how this is going to work. Activities, you're going to be referring, you're going to be doing patient follow-up, closing the loop on the communications and referrals. A lot of workflow and mapping is going to need to go on, and the evaluation of the referrals. And what are the outcomes? Are we getting what we need to get? At the end of the day, did Martha Sue's A1C get under control? If not, we still need to modify and work together to try and tweak it, or, you know, we need to escalate because there's something else going on. So gives you the idea. All right, case study. Now, this is where y'all get a chance to chew on some of what all of you heard. So if we think about Lucia Martinez, she's a 71-year-old living with a history of diabetes. She had a recent clinic visit and her A1C was out of control. It was 9.3. And what I, the clinician, am being held to account is her A1C should be 7 or 8. So she's running them up. Ideally, I wanted it 7. That's what my health insurance plan is. That's what CMS wants the health insurance to have. So, you know, the mothership, CMS, is saying everybody's got to get Lucia's A1C to 7 and keep it there, right? So she lives alone. She's in a rented trailer home in Colorado City area, and she's got a sketchy refrigerator and oven. So we've talked about some of these things before. She's currently living on Social Security at about $15,400 a year, and that is just not making her ends meet. She's probably running, I don't know, $700-800 a month in the home. The truth is told, she's dual eligible for both Medicare and Medicaid, and she's been identified by the clinic when she was just there with a 9.3 hemoglobin A1C, She was identified as having food insecurity, housing instability, transportation insecurity, medication adherence issues. They're all getting in the way of her ability to manage her care. And so, the floor is yours, people. Thinking about, got reference materials now that you have the slides, whatever. What are some of the potential impacts of the health-related social needs on her clinical health outcomes? She's diabetic. The doc says she's got all of these insecurities. What are the impacts?
Well, she needs an intervention. If not, she's gonna continue to go south.
And what does South mean for people who are not clinical?
It's gonna be a high-risk patient that's gonna continue to spend clinical dollars.
A lot of
because
dollars.
They're gonna continue to come in.
Yeah.
Like
she
she
could
could
go
end
on.
up with the amputation, she could start having vision issues, the ocean might start boiling, yeah.
No, the ocean's not gonna boil for that.
Okay, all
I
right.
wish it would for the see what's going on. It will not. She is a small fish over here, larger.
But for example, like with a lot of people, like say she does get an infection on her foot, she has part of her foot amputated or part of her leg, then she's got mobility issues and her health is just probably gonna become worse. Maybe she can't even get in a trailer anymore because she needs a walker or a wheelchair. She can't walk well. So where she's living doesn't even meet her needs anymore. And maybe she doesn't have a car, maybe she does, maybe she can't drive anymore, it's her right foot, I mean, it just goes on and on.
Mhm. Right.
She gets
Anything else,
well
anybody
enough.
else would want to add in? Pops to mind, you maybe have had a client like this before. No? So what social care interventions could address her needs?
Transportation. Big one.
Hmm?
Transportation.
Transportation for sure.
A community health worker going home to her home to create an assessment of issues that are affecting the social determinants of health, issues that are affecting her health outcomes. Social care interventions can mean a lot of different things with specific patients.
Yeah, but keep it in their box, right? Even within the 10 questions, you're exactly right. You can wrap around with other things, but to be eligible to bill for these services, you gotta stay in that box, I'm sorry.
So the time in CHW might, I'm wondering, Patty, the time CHW might talk with her about, does she understand A1C? Does she understand how her meds or her insulin relate to that and her, when she eats, that doesn't count? Or does it? count to food? It does count. Okay,
What else? You go back to some of those handouts in the earlier stage where we talked about what are the HRSA impacts on diabetes, heart failure, and COPD. They'll give you some kind of an idea. Okay. Can CHI services be engaged to help her? Yes. Right? So then, would time spent identifying the resources needed to address the needs be counted in the aggregate CHI time spent in a calendar month? Yes, yes, it absolutely would be. That time planning, and trying to figure out what the intervention, you're developing your care plan, all of that would count. Would time spent traveling to see her count toward monthly billing?
Unfortunately, no.
Unfortunately, no. Yes, that is correct. Can your organization be reimbursed for the time spent attempting to address that HRSA, even if you can't successfully address the identified social care need?
Yes.
Yeah. There you go, yes. Okay, so you don't have to deliver a full-blown outcome. You don't have to change her A1C. You don't have to fully resolve the housing issue. The time spent, you are getting to know and wrap around this patient and getting to a deeper understanding of what maybe is going to be part of the secret sauce that helps her get control. Okay? All right, so a draft pilot project for anybody who wants to accept this assignment. So thinking about just, a draft objective would be build and test an integrated clinical social care delivery system for whatever county, Cochise County, for 3 Medicare fee-for-service beneficiaries at Hospital X, whatever, FQHC, Chickasaw, right? All right, then, a sample of steps of things that you might, want to do. So you don't want to do this willy-nilly. You need to know that they're a Medicare fee-for-service beneficiary, right? So go to your medical records people and run a report. Who do we have that's fee-for-service, dual eligible? Your electronic medical record should be able to tell you that. Decide, either looking at the data, is diabetes the thing we need to look at? Is depression the thing we need to look at? Is heart failure or hypertension? Pick a disease state that you want to focus on. I would recommend it would be either the heart failure or diabetes or COPD, because those are very expensive, very consistent things that are present in rural populations of this order. Pick what it is you want to do, and then go and dive into your record and identify 2 or 3 patients that you want to work with. Then identify with CBO who you think can help with what's going on. You could mine from your record if you're collecting Z codes already, and you know food insecurity is a big one. Sort of have that on deck in your mind. We need to go to the local food pantry or the food bank or whatever to bring them in as our partner potentially for this. But look at assessing, bringing in those patients. They all have to have an annual wellness visit. You know that their A1C is running out of control. You work it hard to get them in for an assessment, and then you start to put together the process. So you identify the CBO that can help address whatever is needed for those people. And I would take it by one thing: do food security. Don't try and do all 3 for her. Just pick one that you're going to work on building that referral relationship and that work with that CBO. Does that make sense to you? Because this is a pilot. We're not trying to pilot. We're not going to try and do it all at once. You just need to build that pathway for how you're going to work on food insecurity with a select group of people. You're going to develop the agreement of service, which we talked about. Establish a care plan for the patient with the PCP and the CBO. What's that going to look like? And of course, we always share that care plan with the patient. We don't act on them or around them. It's their plan. So it could be the 3 of you, the CHW, the clinician or nurse, and the patient in the room agreeing this is the care plan. Let's see, we're going to establish a referral process for the specific support services using whatever platform you're going to use. If it's your electronic medical record, if it's going to be Contexture, you want to, and your clinicians are going to want to have that electronic referral capture so that you can close it. Develop the workflow for the CBO to deliver the service and do the documentation. So you've got in-house work that you need to do in your own shop, figuring out how you're going to do this work. The clinician needs to do the same thing, and then you need to come together. This is how we're going to do this thing together. You're going to work through what documentation is going to look like and all of that timing. And a lot of this happens as you're developing your agreement. Some of it's gonna be hit and miss. We put this in the agreement and it's not playing out like this. So rewind, let's modify. Things like determining how and when, what's the cadence of our meeting's gonna be, if we get together as a clinically integrated team, how often are we gonna touch base? Once a month? Do we agree it's so small, it's just gonna be ad hoc? We just need to talk about this one patient this month, but I'm figuring all of that out. These will take place. Number 12, test the application of the new codes. So that's when you start to put together the documentation. What's the Z code look like? How is that in the problem list for the patient? And now we're getting ready to the point that we're gonna be prepared to bill. So your billers are figuring out, do I have all the pieces and parts that I need to put what I think is a credible claim in? Prepare and submit the monthly claim, the invoice for reimbursement, reimburse the CBO, figure out what that process is gonna look like. Repeat the assessment no sooner than 6 months to see if you're having an impact with them. CMS will not allow you, and nor should you, as we talked about earlier, you don't want to over assess people. You know, they will start to know from other indicators or A1Cs getting under control. So there's no real need. You can sort of do that anecdotally. Lucy, how's it going? How's that? I know we talked about you have some food insecurities. How's that? I highly recommend that you track your outcome data on the A1Cs or on the hypertension control so that you start to have a story to tell, particularly as a CBO, that we believe that our efforts are really contributing substantially to, so that when you go out to find other new partners or renew agreements, you can sort of point to, here's the goodness that we brought to this process. I say PDSA, that may be a term that many of you don't know. It's Plan, Do, Study, Act. It's a rapid quality improvement strategy. So as you're doing something, don't just put the plan in place, keep the plan. If it's not working, be looking at it, talking about it internally and as a group. And if we need to change the way that we're doing it, do it. You know, that's why you're doing it small. So you're not having to set all these policies and procedures in place and then it was flawed. You want to build it first before you build in the policies and procedures. And then repeat, rinse and repeat, and then expand. If it starts to look like it's working, then go to the next health-related social need. And if you have the capacity, continue to do some more diabetes patients, but then expand to some hypertensive patients. So that then you're starting to build that referral network and that capacity. It may be that your community health worker will be able to field all of that. And it may be that there is a community health worker group that specializes in food insecurity and doing that work versus transportation. Okay. Any questions about that? We're almost there. I got one more slide. And we're not going to spend a lot of time on this. You have a copy of this on your table. You will get the Excel spreadsheet from Arturo. It will be in the magical Google Doc. And it is a capacity survey for you and your organization to think about. There are high-level buckets of things to address sort of within your operational system to consider. And there's ticking and tying across the different organizations to make sure that everybody's kind of doing their thing. So there's accountability that needs to be established. Leadership needs to be on board with this topic. Responsibilities need to be negotiated within an organization. If people assign jobs to do this, this is not something that we're just picking up and doing ad hoc. You got to be serious about this. If a referral comes in to Contexture's point yesterday, you need to respond to that within 2 days, certainly within 4. You are now part of the medical system and there is responsibility and accountability that comes with that. So your bosses at the table with the CBOs, and even within the clinics, you need to make sure that people are designated within their position descriptions to do certain things to support the system. Don't go running out and doing it right now until you've tested it and you decide it's what you want to do. But things to consider, and that's why it's saying it's being fully developed and it's deployed, developed it completely, you know, we're sort of in the developmental phases, but it's a work in progress. It's not applicable, that's okay, there's a lot of stuff in here, some of it'll be applicable, and some of it won't. But, wow, we hadn't even considered that, those are the ones to pay attention to, you know, to start to think about, and strategically, how are you gonna start to build this all out? Because you're not gonna do it tomorrow, this is an evolution. But it gives you a way to look at, like a baseline where you are now, and then pull it out every 6 months, whatever, and see if you're making progress. I've used a similar type of a tool with a system of care where, you know, like accountable care organization or care coordination, because this is care coordination on steroids. This is team ball. You are not just within a clinic managing care, you are now managing care with other people outside. And so making sure that, that your partners even are doing this. I mean, this is a tool that we could expand out to what's the payer doing? What's the hospital doing? What are their responsibilities? That's what we've done in Buffalo. It's sort of like, okay, here's my relationship. I have to have a relationship with the CBO, with the payer. I have to have responsibility with the hub. I have to have responsibility with primary care. And what all does that? Each one has its own steps and nuances that, and reciprocally, they need to have an agreement with you. They need to have. They need to. All right. Just make her stop. We're actually on time. Anybody have questions? Overwhelmed. You probably need a little bio break again.
A lot of good. Yeah.
Okay, so why don't we take a break for about, I don't know, 10 minutes?
Yeah, 10 minutes.
10 minutes, yes, ma'am. Can you provide an example of duplicating services? I'm sorry, can you provide an example of duplicating services? That would be if you were doing chronic care management, so the 20 minutes to call the patient and checking on medication reconciliation, and that stuff. And then you counted those 20 minutes in the 60 minutes that you were billing for your CHI circuit. Because you were educating the patient, you were helping them get medication that they needed in that 20 minutes of your chronic care. And but you very well might be, your nurse might be. You can't do whatever that.
So the medical assistant will be doing that.
Yes.
So not part of the system, right?
But your biller has to document and say, nurse X was doing all of this and she was responsible for it, and I've got proof of it. And then CHWY spent 60 minutes with the very same patient at different times, because you're gonna have those timestamps. So nurse X cannot be talking to the patient at the same time that CHWY. Does that make sense? All right, so let's take about 10 minutes, and then we'll reconvene to talk about, give you a chance to let that all sink in, and we'll talk about what we think RAzCHOW can do to help support and expand on it. And I'm gonna turn that sort of over to you, Mr. Network
good.
Leader.
Good, we're gonna mute the.
Yeah. No. I just haven't played this.
Bueno, somos. Peppermint.
I thought you had to
Yeah.
I have a.
Oh, yeah, but it is, that's what I wanted to, you guys got it. Trying to be in all places at once. I'm just like, oh, she has no. That might be it. It's true, yeah. Yeah. All right, everyone, we're gonna start up again. So in this last part of our days together, we wanted to do like a little bit of a group discussion with you all.
Yes.
Thinking about what the role of RAzCHOW is and, you know, what Anne was just talking about and piloting and building the member capacity. So I want to give the floor to.
Yeah, gracias, Dulce. I was just in the back with Maria Chapoy and we're like just trying to capture, but there's so much information. And as we were discussing with a lady that came earlier, don't just pay attention to the big details, because the small details are gonna have to be digested small one by one. And during this conversation, and thank you, Anne, for another amazing presentation. We're gonna have a presentation, right? We're gonna be able to share it as a PowerPoint, and so people can write notes in there and put like comment, this is where I need to concentrate. But one of the things is, what is the role for RAzCHOW? What do we do from here on? And what do you all think, what are your vision for us to continue working on this? And we were talking in a small group outside, and I said, well, my perception is that even in the own organizations that represent RAzCHOW, we're still not in the same level of understanding and knowledge about all this that we're learning about. So I think that we need to really start at the beginning. That's my perception, but I do want to hear what you think, where we should be. Sure. Okay. All right, so thinking about that, what do you all believe? And remember, Anne is stuck with us for some more years. So we have 3 more years of this that Anne's gonna be available to like reach out. Hey, Anne, we're gonna have a meeting. Is there anything you can come and share with us and really help us still move forward? But at the same time, I wanna also acknowledge that here in Arizona, we do have a lot of individuals that are really concentrating on learning and digesting and making sure that we are understanding. And one of them is Allison. I was like, walking in as I was on you. So yesterday I was talking to Allison and Dr. Molina, how we can really partner and really come together to make sure that we all understand every single small detail that we're not totally really clear. And with that, I just want to ask you all, where do you believe that we should continue? What is this next step? What do you envision for us to continue working?
And also, what are your particular needs for the organization that you represent in the medical?
And we'd like to open this up to discussion here in the room for everyone to participate and then everyone virtually as well.
And there's no way you respond in Spanish if you want, that's great.
Correct. We have some folks taking.
We also do have a comment from Jill in the chat. She says, great work and great presentations. Before getting into details for billings for services, I would like to back up to the modeling of the Medicare reimbursement calculations and suggest that anyone in Arizona showing these calculations use an hourly rate of $25 an hour for CHW. $20 an hour in Arizona is not a livable wage, and we would be ensuring that CHWs are not employed in fair and decent jobs. When we work towards certification, yeah, thank you, Jill. When we work towards certification in our state, one of our main goals was to ensure that certification led not only to reimbursement mechanism for services, but also to improving the working conditions of CHWs in our state. So thank you so much, Jill, for that comment. If anyone has any reflections on that or on what Floyd was talking about earlier.
Go higher than 25.
Yeah. And I think, like the next step, it will be for me, to have more people getting the certification maybe, which somehow they don't have it yet. And also, I think, as I was talking with Arturo earlier, we can have like a kind of training in a CHW level, so they can understand better how it works. Because I work in a clinic and I have an idea, but some people doesn't have it, so we can have like a kind of map and say, CHW is gonna do this part, and this is clinic, and this is billing, and this and that, so they don't worry about all the information. Like, maybe getting the data and maybe report data and study data can be our part of the job. But billing and all of that is gonna be providers and billing and all of that, so maybe we can do like a map. Or no, like a organigram and explain how it's gonna be a CHW work and the other part they don't need to be worried, just to understand it. To kind of clarify like the CHW roles, like in that context and everybody. Exactly. And then like break it down maybe by departments and say, this is CHW, this is clinic, this is other departments. And maybe having like a kind of trainings and how we collect the data, and yeah, I think.
So training capacity building for the network to totally understand where we're really moving forward.
Maybe some kind of organizations that CBOs can partnership to get the goals, to work with the goals too. Like hospitals, like you say privates, and kind of have an idea which organizations that they have close and they can partnership with it.
So I have a question, and I love the chat that Jill put in there about the $25, because I totally believe that CHW should begin at least at that amount. So, if you're gonna be putting that $25, shouldn't be the CHW be paying $25 to begin with, or can you be paying the CHW 16 or 17 and then charge $25?
You're not, you're charging them the 90% of the billable. It's up to you internally, how much you're paying your people.
Yeah. But we should encourage, right?
Absolutely. I just went with your state average.
Uh-huh.
So that's what it would look like. If your budget can handle it, go higher. Absolutely.
Just to make sure that when we talk about this, that we encourage the organizations that are gonna be doing this to make sure that they are putting that level of salary for the CHW set on. Everything.
You know, this is complicated work, and this is important work. So be thinking about, would it be 30? The national average for CHWs is rising all over the country. Everywhere, between 60 and 90,000 a year, people. That lot depends on what your hourly week is, for the 35, 37, 40. What are people in the
And everything is depending on states as well, salaries. But no, thank you for, I'll say that, but I do believe as RAzCHOW and as when we continue developing that language and developing the process, we should encourage organizations that are gonna be following what we're doing to really raise the salary of leaders at least like Bill said, $25.
Yeah, Jill has another comment, so she said this is our opportunity to talk about what should be, not what is. So I feel like it's an invitation for us to kind of
That's my
imagine what we want to see.
And I think this is also the moment where you can say, with the new Medicaid billing opportunities and the new Medicare billing opportunities, you can justify potentially 30 or whatever you want. You know, you can, and do that calculation of like, this is what it looks like at the current salary, and here's what it could look like when we are billing set 60% of their time.
Because we do our mission and vision and goals for RAzCHOW is really get to that care coordination, integration, sustainability, but also equity for our communities, which is CHW workforce is our community that we are focused on. Because at the end, we develop that equity, our communities across Arizona will be healthier and be impacted by the work. But I think that it is not only just moving towards, but really developing the policy and continue advocating for the CHW.
Thanks. Yeah, hi Jill, this is Susan Coons. I feel like my head and heart are kind of with you. I feel conflicted a lot about the growing opportunities for CHWs, but also the dangerous potential of losing what a CHW is. If you think about, I mean, I've worked with several of the health centers in the room, I've worked with all the CEOs who are in the room, and I see how things are changing. And, you know, we think about trusted member of the community that knows the community, that is language and cultural appropriate, you know, and when money starts to drive the conversation, I mean, it's a good thing, but when money becomes part of the equation and healthcare is a business, there's the potential, and Flora and I have talked, a lot of us have talked about this, of pretty soon, they're just hiring anybody to put in these positions. What training do they have? Yeah, they've gotten certified. Do they have the personality, the heart, the love, how they're going to do this job well? Or is it going to become sort of like, you go to medical assistant school, you medical assistant, you go to, you know, is it, I'm worried about that. I think that, RAzCHOW, everybody involved, RAzCHOW is our CHW association, the CHW coalition, all the allies in our state and on the country, I think we have to really keep this in the conversation. And I've actually seen it with some organizations that, for example, meeting with an organization to see if they're interested in joining RAzCHOW. It was so clear to me that the interest was probably 95% financial and 5% about maybe improving the quality of life of those people. They want their clients to have better health outcomes, to have better value-based reimbursement, or go down the path of this. But so anyway, I'm probably like a worrywart, and I think I watched too much news, and I read too many things on my phone that are making me worried about things in general. But I think this is something we have to really protect and figure out a way to protect that. And even the CHRs, there used to be a CHR association. IHS doesn't have that anymore. A lot of the CHR programs are not connected, and that you're not getting my feeling. You all are grant funded, Chad, and you've been able to do a lot, but through IHS, they don't have funding to really build their workforce, keep them trained, and I don't know, it just worries me. So thank you for listening to my worries.
No, I thank you, Susan, for that, because we have had those conversations, and I do believe that's why it's important when I say we need to really think about this and look at the steps. And when I say involve the CHW organizations, we can do a lot with what we can contain, but we cannot do much with people out there. And I have mentioned this before. I have so many emails in my inbox of individuals that have nothing to do with CHW, And not certainly they're interested in developing CHWs and working in certifying as CHWs. And we can't do anything, we cannot control that, but we can control and developing a model that really works. And as the association, one of our things is making sure that the essence of the model is not. Essence, that's the word, the essence of the model is not lost, so we will continue working. on that. Jill wants to decide.
But wait, Jill, are you responding to this conversation?
Yeah, can you hear me?
Yes, we can.
Okay, I just wanted to respond, Susan, I absolutely agree that, so the model is trying to show what the model can sustain, and the model can certainly sustain a sustainable wage for community health workers, and I think we have to be really careful because absolutely positively, we want to protect the expertise and true role of community health workers, but I don't think that we want to protect it by not providing them with equity like everyone else in terms of their wages, working conditions, et cetera. So it's a balance that you're talking about that I think we have to be really open and honest about. All of the information that was shown today showed how key community health workers are and what expertise they bring to the table. And we have to talk about that in a way that at the same time really protects the true role and the true expertise of community health workers and make sure it's linked to a decent standard of living, right?
Yes. Thank you, Jill.
Yeah, I was gonna share that, one of the next steps, as a CBO, we think that maybe will be more training or workshops, with similar information, but more tailored to, the non-one. Like, those are not clinical settings, so I think that would be very helpful for us.
Thank you.
I think echoing what the young mentioned, I think as a CFO, it's been kind of hard to navigate the reimbursement process because it's in theory, it's like this way, but then once you start looking into the logistics and what it really looks like in the real world, it's not as simple. And I think as CEOs, we're a lot more limited to, is it realistic for us to go that route? Or does it make sense to continue to be grant funded community health workers and focus on that aspect instead of trying to navigate this other side that we do for clinic-based CHWs. So as a member, I know for me, that's something that I really knowledge that I need from coming to these meetings and discussions and okay, what is that doing? What are other CBOs in the state doing? How can we troubleshoot and like share ideas as to how to navigate these new opportunities?
And I think for Chiricahua, at least like we have been changing for trying to get reimbursement different ways. And it's I think at certain point you lost the, like you said, the point of be talking with the people and get the information, get the touch with the community and having the time to speak with the patient and hear the concerns, the social determinants, because at least for us as a community health workers, we started doing the COVID and then the COVID needed to be charged. So we started to check in and we started to bring computers and do a check-in, run insurances, get information, prepare tools and all of that. So it was a lot of information paperwork that we didn't have, like with 3 people in the fields having at the lunch times all the people together. So it wasn't easy to get all the people, like the time for each one, like a one-on-one time. So I think that's why Chiricahua went with separate community health workers. So we have the outreach team and we're the ones having the community. We try to have the time to hear the people and bring all of this to the clinic and we can have the integrated team going to follow up, but I don't think it's enough. Because yeah, at certain point, having the money is a lot of work and concentration too, because we had a lot of trainings At certain point, we didn't have the time to do like several events during the month because we needed to be in trainings and practicing for billing and all of that. But I think it's a process. I think right now, my whole team is confident with the trainings and getting information, and with time we're doing the time to get the information from the patient again. Like we were concerned for a long time, but I think now, I think it's a long process, and I think all of us will need to go through that. And at the end, I think the only thing that worries is that once we have the people trained on that, and we lost the grants, so we need to change for another community health worker or let them go. And that's the concern, that once you have it, everything like it's perfect now, the grant is gonna end in May, maybe, and then we need to get another people or lose this CSOs and get a different one and train them again. So that's a concern for us.
I think it's a big concern as well, because the way I'm seeing it is like having CHWs to be working as a community-based organization and just focusing on the outreach and what the CBO is doing. And then having another group of CBOs or group of CHWs are going to be focused only on the billing portion of it and learning that base of the organization, and we want to integrate it into a community-based organization, because they can either be doing this or they have to be doing this. And part of also the CHW is having that connection with the people. And it's not just when you separate it into those 10 questions, it's very hard for a CHW not to go further, because that's the way the CHW does. They go a step further because we want to make sure that we're capturing and we're actually assisting that person. And that's what I'm thinking, this is CHWs for this, so CHWs for that. So
it's really creating the capacity building for CBOs, organizations to develop their own work plan and business plan. You can really put it together to see how they're gonna function, because every single organization is gonna function differently based on their capacity and the structure. So I think that's business, develop business plan. I think that'll help a lot.
And I would just add too, just building from these important reflections, maybe the RAzCHOW also is in a really important place to put up those guardrails to protect the role of the CHW when transitioning, because what you're saying is really important. It's overwhelming and it takes away the time, and it could affect you in ways that are detrimental. And I think, Anne, you had said, the system, if they want this, they have to put their money and their people towards it. So it isn't, the burden shouldn't, I think the RAzCHOW can play a role in protecting and encouraging best practices around how do you, center the CHW so that they are able to focus on their work, and that the organization builds the capacity for all those other people that need to do the work, that other work, that technical work that's not the goal of the CHW in this process, I think, something like that.
We were talking about that with,
Yeah, you all were seeing.
And I think it's hard because we're gonna be the first generation doing the transition.
Yeah.
So we're not gonna be seeing it.
what did you say?
Just that's where emerging community care hub could potentially ease that administrative burden as an option. I mean, again, very long time coming, but something to explore, because they would handle the billing, they would do trainings, take some of that burden off of the CBO or RAzCHOW. RAzCHOW becomes a partner in doing the training. And sky's the limit on what that could mean, but they would do the billing in theory for you, negotiating the contract. So all that stuff, CHW can just be a CHW. It's like making a referral to the cardiologist. Cardiologist does what the cardiologist does. And we, just to add a little bit, when we did a conference with community health representatives talking about these issues, not so much Medicare, but Medicaid. We were intentional about, we had the CHW bring the biller, the CFO, the CMO, the people that need to be in the room and hearing the information, so it's not landing on the shoulders of the CHW. And I think that was an overwhelming conference. I know I felt very overwhelmed and I could see it in the faces of the CHWs. But I think, or the CHRs, but I think if we continue, I think those folks have to be in the room with us. To share the burden and the loads if you don't feel that it is all of your responsibility, because it's truly not.
Thank
At least
you.
that's how I feel. It's not.
I think that's why important that each generation can develop their own capacity building for what they're gonna be able to respond to and the support that they have with them and what they're gonna be able to look for support on outside their organization. That's why I say they have to do the work one and that's probably gonna be function.
Yeah, who's gonna be doing that?
And that's gonna be individual for every single organization.
Thank you all so much for those important reflections. We do have one more comment in the Zoom chat from Emily Riddle. So Emily says, in some cases, being able to show the economic benefits of having CHWs in medical settings does help, but it is hard when it's not enough of a hook and bite for medical settings. Community cultural acceptability of the role of CHWs is also something to be taken into consideration. There are other countries that have been ahead of the game in this field, where the roles of CHWs is very normalized. It is good for inspiration, but it really has been years of continued effort and troubleshooting. Rome wasn't built in a day. Thank you, Emily, for that comment.
And Emily's with Graham County.
Brown County. Thank you so much, Emily.
I also know that we're getting really close to noon, so an effort to be mindful of time.
Yes, and just to let you all know that we're having lunch here, we're providing lunch. And also.
On the agenda.
It's not-
One more.
You were in charge of announcing.
Yeah. She's my champion, I said. And just to let you all know that after the meeting, you will receive a follow-up email with all the presentations and handouts and materials. Also, you will receive a post-meeting training survey. And yeah.
Like evaluation of the.
Evaluation of the training and presentation, and we'll also seeking for your help and assistance to identify future trainings and future topics of interest for the program. Okay.
I want to say I'm so impressed, Sachi, that you're still on our grant management, which I forget her exact type.
Project officer.
Our project officer, she's still on there, which is so hard to listen in remotely when there's people talking in the PowerPoint and translation. And I want to mention Majoline Begay was here yesterday. She drove to the Navajo Nation at 6 a.m. and had a outpatient surgery and she's on. I'm like, oh my gosh. We have some very devoted members. Thank you, everybody that hung in there.
Thank you.
Yeah, Sashi, she was about to say something because I saw that she unmuted.
No, I just wanted to say I'm here and the video and audio was pretty clear most of the time, so no worries about that. I really enjoyed listening to your conversations and all the thoughts you all had to share over the past couple of days. And I just wanted to say thank you so much on behalf of HRSA for your continued work on this grant and for everything that you do as a part of your organization. You all are amazing, and I'm really looking forward to continuing to work with you over the course of this grant.
Thank you.
Thank you, Sachi.
Yeah, we do want to thank Anne also, for giving us that wonderful presentation. I don't know if you have any like final words or reflection for us.
No, y'all should all get a medal, because that was a marathon. You hung in there. Thank you. But I'm around, just ask away. I'm happy to talk to you in meetings when I can.
Thank you so much. And I know Maria Chaboya, she has something to share with the network.
Oh, it was just, for people who work in, Maricopa County in the north. I have some flyers, we're still hiring care managers, so if anybody knows anybody who needs a job. Please take a flyer, and send them over to us.
Where is the area?
Northern Arizona and Maricopa.
Hmm.
We're done hiring in the southern part, so
Okay,
please take as many flyers as you like. That's it, thank you.
thank you for sharing. Well,
Thank you to everyone online.
next meeting, you will have a really good agenda.
Don't follow my friend. Maria, for lunch line. But I'm not saying that. No, you got it. Huh?
No, I helped out.
Come on, everybody, let's go in. Let's go in, come on. Come on. It says Maria started.
From here.
Empezaron a